हाँ, yeah. So I already told you all these figures, some of them important which we have achieved. 20 NMR, IMR 28, 5 MR 32, MMR is now less than 100, the latest says TFR. So these are all shows, where ASHA has contributed. Our most peripheral health workers, they have contributed in all these fields. You can see institutional birth has increased, contraception rate has increased, 24-hour home delivery जो facility में checkup होता है, that has increased. Exclusive breastfeeding has increased. Breastfeeding within 1 hour, that is again an area of concern. क्योंकि हमारा institutional delivery आप देखिए 88.6%, but breastfeeding 41% only. और last NFHS से हम बाद में आएंगे, only 0.2% increase हुआ है. और आप देखिए जो नीचे का है, all of you know these figures, but we must again and again discuss this. जो stunting है, wasting है, and fully stunting and wasting, these are the figures. And anemia figure 67%. NFHS 5 has said 67% of our children are suffering from anemia. So ये सब में आशा की बहुत योगदान है. एंड आशा के लिए जो प्रोग्राम्स हैं वो उसका क्वालिटी के ऊपर सारे डिपेंडेंट है. हमने बहुत अचीव किया है, बट आगे के लिए हमें क्वालिटी इंप्रूव करने का जरूरत है. ये है आशा के पास बहुत काम है, सब कुछ है, बट ये जो हमारा RCH प्रोग्राम उनका फर्स्ट प्रोग्राम है, उनका जो श्रेय है उसका बहुत lot of these are due to ASHAs. So we have to motivate them and we have to see and handhold them for quality improvement. ये NFHS 4-5 का हमने तुलना दिया है. The brown upper bar is for NFHS 5. The next one is for NFHS 4. So you will see in all these areas, institutional delivery, skill birth attendance, everywhere there is improvement. Somewhere it is more, somewhere it is less. But all these have been contributed by our community-based programs and the work that ASHAs are doing. So क्यों बच्चों को क्यों हो रहा है न्यूबॉर्न, क्यों डेथ हो रहा है, आप देखो. So many of you may be knowing child health nodals, they know, but I will specially draw attention to our community program heads and those who are from the districts and states that the major cause of neonatal death is, you can see that big blue pie, वो जो prematurity and birth weight. 46% are because of low birth weight and prematurity. So इसमें जो है हमारे रोल्स बहुत important है जो आशा करते हैं. ANC केयर, हाई रिस्क लाइन लिस्टिंग, हाई रिस्क का फॉलो अप, हाई रिस्क का रेगुलर चेकअप, इसमें बहुत important है. Of course, birth asphyxia and birth trauma, they are facility based. This again can be improved if the mother comes to the proper facility in time. Again, ASHA can play a big role. Neonatal pneumonia is the third cause. Huge number, 17% are dying. So this is again a big area where ASHAs can contribute, and there are other things. So what is important here, that contribution, quality of work in our peripheral worker, in our community workers, they can be very important, and especially those who have joined recently, our CHOs, and they can also improve it dramatically if they are involved in it, and they take part in this in supervision of our ASHAs, and also doing, walking along with them. So there is a big scope of improving this. We have to, in neonatal mortality, we have to come down to single digit. So we have to hub it. we are already now 20 average. So we have to make it 50% less if we want to achieve SDG target. Next. So under five children's ka, this is an analysis. The pie shows the analysis. What is the cause of those 32 children out of 1,000, how they are dying? You can see again prematurity, birth asphyxia, their complications, because they continue. That is such a big pie of neonatal mortality and morbidity. So here again, this is again the major cause, but most of them die in the first 28 days. So आपको पता होना चाहिए that first जो एक महीना है जिसके लिए हमारे HBNC प्रोग्राम डिजाइंड है 42 डेज के लिए, 28 days में 65% of under 5 death happens. Out of 32, 20 are dying in the first 28 days, the first 4 weeks. Next is again pneumonia, and another big pie is diarrheal diseases. So reducing prematurity, reducing low birth babies by proper antenatal high risk care and other routine care in ANC. Then pneumonia, early detection, referral, as well as diarrhea, giving ORS, zinc, and proper treatment, very simple treatments for diarrhea. So we can, 3 big pies we can actually reduce. इसमें भी हमारे community workers का बहुत बड़ा योगदान है. They contribute a lot. So focus areas, what are the focus areas? There are in child health, there are certain facility-based program where sick babies are there, but there are equally important for child health are the community-based programs, that is the HBNC, HBYC. Then we have this, campaign programs, SANS, which is to prevent pneumonia and for early detection and management of pneumonia, so that deaths are avoided. Pneumonia is preventable. Deaths due to pneumonia are also more preventable. Even if pneumonia occurs, if the child is referred in time, death can be avoided to a large extent. Then we have other programs like diarrhea control programs, not to forget the various nutritional and initiatives for our anemia, which you saw that 67% of children suffer for anemia. So that is a major area where we should be able to take control of malnutrition, sick and severe acute malnutrition children. We have NRCs for complication management, and there are several other programs which are facility-based programs. So I want to draw attention here for those who are present here for the community-based program, which can be actually helped by our health workers, and their proper referral in time to the appropriate facilities, so that our facility-based programs can take care of the rest. So both should work in hand. The referral quality should improve, and they should improve early and proper referral. And then when they come back from the facilities, their follow-up. So all these go hand in hand. Early detection, referral, community-based programs, facility-based programs, then coming back for follow-up in the community. So all these things actually will help us to improve our mortality and prevent all the preventable causes of death, जो हमारे left side में दिखा रहे हैं. Next. So HBNC program, you all know, it is an old program. 2011 it started. 6 visits for institutional delivery, 7 visits for home-based deliveries in first 20 days, 42 days. So you must, the schedule also, and the most important, what is to be done. Because next afterwards, we'll see that our reach has increased. Our reach for HBNC has increased a lot. But what are the aims, what is to be done during these visits, that needs improvement, that needs to be, there lies the role of our supervisors, who can actually improve, in detection of, ashas, how much they are detecting, क्योंकि पर्पस वही है HBNC विजिट का, जो अगर कोई बच्चा सिक है, उसको कॉर्ड में इन्फेक्शन है, वो पता करे, उसको प्रॉपरली काउंसिल करे, ऊपर भेजे अगर जरूरत है, सेप्टिसीमिया वगैरह होने का चांस दिख रहा है, फीवर है, बर्थ डिफेक्ट्स कुछ है कि नहीं वो पता है। मदर के लिए मोस्ट इम्पॉर्टेंट, मदर के लिए ब्रेस्ट फीडिंग के लिए मोटिवेट करे, काउंसिल करे, ब्रेस्ट फीडिंग एस्टेब्लिश करे, बिकॉज दिस इज द पीरियड, अर्ली पीरियड व्हेन ब्रेस्ट फीडिंग सबसे इम्पॉर्टेंट है फॉर द चाइल्ड्स ग्रोथ एंड डेवलपमेंट। Exclusive breastfeeding, motivating mothers for exclusive breastfeeding, showing them the way. So that is again a very important thing, because you saw in the previous slide that exclusive breastfeeding, it needs to improve much more, because that is the, आपको मालूम है अमृत है, उसके लिए सारे डिजीज प्रिवेंट होता है, बच्चे को ग्रोथ होता है, वी कैन इम्यूनिटी बिल्डअप होता है, so many things can be achieved through exclusive breastfeeding. और बोलने के लिए वो आसान है एक्सक्लूसिव ब्रेस्ट फीडिंग, बट करने के लिए मदर्स नीड लॉट ऑफ सपोर्ट, लॉट ऑफ मोटिवेशन, क्योंकि बाहर दूध अवेलेबल है, कोई भी मतलब मोटिवेट हो जाते हैं उसको बाहर का दूध पिला दो, बट ब्रेस्ट फीडिंग के लिए जो चाहिए मोटिवेट करना, उसको सपोर्ट करना, उसको रस प्रॉपरली बताना, वो हमारे आशा के काम है। दैट इज वेरी वेरी इंपॉर्टेंट इन द HBNC विजिट्स। पोस्टमार्टम केयर ऑफ द मदर, अगेन मदर्स के लिए अगर कोई डिस्चार्ज है, कोई सेप्सिस है, कोई फीवर है, दैट इज अगेन एन अपॉर्चुनिटी दैट ashas can visit during this. Family planning, so that the family, next childbirth is delayed, or if there is the family is complete, it can be, permanent methods can be used. So all this can be motivated by ashas. Reference of sick children, I already told, that is the most important thing, because early referral will save the child and prevent death. Doing the follow-ups, already I have told. Next. So figures show that this year till second quarter we have achieved a lot. 69 lakhs newborn have been visited. Sick newborn referred is 3.6 lakhs, and ashas we have around 9 to 10 lakhs. So these are figures which shows us we have the means, we have the tools, we have the everything we have at hand, and our quality visits will improve a lot of our mortality, which were in the previous slides. Only Goa and Lakshadweep are not implementing this, but all the other state cities are actively involved in HBNC program implementation of this. This is the second program, again, which starts, after these 42 days. There are 5 visits, 3 months, 6 months, 9 months, 12 months, 15 months, so that, it is 2018 it started, and after that, unfortunately, it got little, implementation, rollout became little disturbed because of this COVID, because all community-based programs suffered because of COVID, but it's very, very significant role. We know that child growth and development is the main area of concern for children. There it can go, help a lot. Nutrition, the exclusive breastfeeding till 6 months, and then transferring to complementary feeding, the most critical area, how the baby from breastfeeding goes into complementary feeding. So that area can be really helped through these visits, these 5 visits which happen in quarterly. Then iron folic acid supplementation starts. For health, again, it is very important. Nutrition aspect, it is the most important. For health, it is very important, how immunization can be achieved for at right age birth for the child, for monitoring of the growth and, the weight of the child, height of the child. ORS, if there is diarrhea, ORS, that can be motivated. Early treatment seeking, as I said, for pneumonia, that is very important. Pneumonia and any other illness, measles, early treatment seeking will prevent a lot of mortality. The entitlements which are given, like JSSK, up to 1 year till the infant achieves first birthday. So that area again can be helped by our peripheral workers. Child development, I told you, unfortunately, if there is some kind of, predisposing factor, either prematurity or some sickness, so development may suffer. So these visits are very important to find out, screen for these development delays, what the child, बच्चों को कौन सी एज पे क्या होनी चाहिए, as described in our MCP cards. So उसके सहारे हमारे peripheral workers, they can easily identify and they can refer, so that our other programs like RBSK program, DIC program, they can initiate early intervention to prevent disability. बाद में बच्चे डिसेबल बन जाते हैं, उसके पहले हमें इंटरवेंशन करना चाहिए. तो ये 5 जो विजिट्स हैं बहुत इंपॉर्टेंट है उसके लिए. WASH program, we know that all illnesses are due to whether diarrhea, whether pneumonia, whether COVID. They all depend on hand hygiene, how frequently we wash our hands, so that promoting that. So these visits, HBYC visits, they can help us in a very big way in all these domains: nutrition, health, development, and hygiene. And incentivization is there for this. Next. So early childhood, I already said that first 2 years of life, very important for growth, for development, for all kinds of development, because the future potential of the child, the intellectual potential, the emotional potential, the brain growth, neurology, all depends on how good care is taken during childhood. And these 5 visits, they promote that. They tell mothers about nurturing care. They tell mothers how to have good practices. Child is very important for every family, but there are certain myths, certain stigmas, certain issues about child rearing. So promoting the correct practices and stopping the wrong practices, ये सारे बहुत important है, जिसके लिए हमारे community based this HBYC program is very important. 72% deaths and diarrhea deaths, 81% pneumonia deaths happen in these 2 years, which can be prevented with if our HBYC visits are done with proper quality and proper intensity. So complementary feeding, I have said, this is one area where we have failed to improve. You can see over the years, 9.3, then next NFHS showed only 9.6. This time it is 11. So adequate nutrition, that is one area. जो कटोरा भर के जो है खाना खिलाना है, early development के लिए ये बहुत important है. Not only this transmission, transferring the baby from breast to other diets, it's very important, and lots needs to be done. Next. So these are the visits. Immunization के साथ we can connect. If the immunization is falling behind, then we can correct it. And as I said, all these areas, the domains, they are held by all these HBNC and HBYC visits. Next. So HBYC, as I said, the implementation process suffered. 2018, it was launched. Then it was, in the first year, it was only for the aspirational districts. And next year, 690 districts, budget approved 18-19, but promotion happened only in the aspirational districts. So far, we have trained more than 6,500 ashas. 5 national TOT has happened, state TOTs have happened. Recently we did the TOT for those left out, 3 places were left out, UTs were left out. We did it. 5.5 lakh ashas have been trained. 6,500 trainers have been trained, and 5.5 lakhs ashas have been trained. Looking at the home visits, 31 states UTs, 404 districts, including 104 ADs have started home visits. So you can see there is a big gap about the in the approval and in the what has happened. The 690 is the latest approval figure. Yeah. So here is a scope that we improve training. Our nodals are here. So please look into these figures. HBYC program is in the highlight. Even now, the Prime Minister Office has said, and we have committed that we will, like HBNC, we will make it universal all through. So there is a big scope for improving this. This year, last year, 21-22, 1.8 crore visits happened. And this year, there is a considerable improvement, because in the first 2 quarters, 1.1 crore visits have happened. So I encourage, I motivate, and I urge all of you to look into HBYC program very seriously. So HBNC, we have various, these resource materials are there, modules are there, trainings happen. MCP card is a big tool. MCP card, proper utilization. So when we go into the CRM visits, we find that, the expected penetration of the revised card is not so much. कभी वो माँ के पास रहता है, कभी वो आंगनबाड़ी में रहता है, कभी वो खो जाते हैं, कभी वो किधर भी है पता नहीं चलता है. So इनका सबको मेरा I will request all of you for both these programs, HBNC, HBYC. This is one very important tool, and it has been actually been very useful for making improvements. So please utilize this, have it, and fill all the columns. It's not only immunization card, it is for all. There are nutrition advices, there are growth advices, so many things can be, mothers can be told about and counseled about. This is a handy tool for both the provider as well as for the mother and family. We have, growth chart. Growth chart filling. All supervisors which will be trained must be hands-on trained how to, Asha should fill the growth chart. That when we go, I personally ask someone, couldn't do it. So please see that they know how to fill it and they do it, because that is one very important MCP card tool to see, catch children early. We see so much of stunting is there, so much of growth failures are there. So we can always take help of this chart. HBNC kit, these are provided to Ashas for making their visits, for making quality visits to the these home visits. Next. So these are again the HBYC tools, materials we have. We have the handbook. We have various job aids, training is there, the trainings are happening, and a revised MCP card again. So these are the various resource material, and HBYC kit is also there, no?
Yes.
This HBYC kit is also there, which again improves the interaction of the mother, helps in diagnosing any kind of delay. This HBYC kits also should be there.
Yes.
Yeah. So it is development for early childhood development. This is very important. Next. Kit is here, of course. Yeah, it is there. HBYC kit. Many states are in the process of procuring. So please expedite it. Make the HBYC visits more quality visits and help all the domains. So these are the various other IC materials are there, posters and brochures. So again, as I said, that normally the urban areas, the slums, the migrants, those who are marginalized, so they are often left out. So special focus have to be given for these equity areas, that they should not be left out. Next. So coming to our today's program, this is supportive supervision. So I'll very briefly say what supervision, supportive supervision is. Next. So we know, I don't know how I can interact with you if it had been physical, because we think that supervision is just making visits, scolding, you are not doing that, you are not doing that, this is not good, that is not good. But those who are present, who will be trained further, it must be made clear to them that supervision is hand-holding. Supervision is not fault finding. Supervision is fact finding and improving it. So those are the areas how we can motivate. How can motivate the supervisors who will be trained, the facilitators, Asha facilitators, the MPWs and CHOs and ANMs. They must be able to motivate the staff, not to scold or not to make them discouraged. Then ensure that quality, like what this purpose is. We know, we have all discussed what are the qualities, how quality can be improved in our visits. So that is their purpose, not to discourage it, to see what problems are being faced, because on field there might be many problems. So how they can be having a realistic solution, how the future problems, prevented, how they can be prevented. Training, all these, modules and all, they should be very familiar with. They should know all the modules by heart, so that whenever Asha needs some guidance, they will be able to provide, they will be able to train, and they will improve their capacity. Give feedback how they are working. If someone is doing well, that good feedback will help her to do more. If someone is not doing well, then support her to do well, and not to discourage to not to do further. Then how to improve the processes. So supportive supervision has huge role in improving quality. All these are quality aspects. Next. So they have great influence, because all supervisors are looked with great respect. They, not because they sign the form, incentive form, but because they learn a lot from them. It needs skill. The supervisor must have adequate skill. They should know the knowledge about the program. They should have skills. They should have relationship. It is a rapport building exercise, teamwork exercise. This already I have said, quality, motivation, successful implementation. See that things are done, and things are done in a proper way. Things are done in a way that will help us to improve their mortality and morbidity conditions. And also help the mothers in good practices. They are role models, teachers, motivators, mentors. So they play a very, very important role in our scheme of things. This is a picture, if you can remember, that when traditionally supervision was being done in a very administrative way, without any checklist, without any, problem solving attitude, without any, without telling them their tasks and standards, and without any emphasis on motivation. So they all run away. All staffs are running away by the supervisor. And the next, supportive supervision should be like the lower figure, where people will welcome you when you have the enough skill to do it. You have a checklist so that you check objectively, not subjectively. Objectively, you must check. I understand you are all getting what I'm saying, because many things I can't tell in Hindi. तो प्रॉब्लम को समझना है, प्रॉब्लम को सॉल्व करने का एटीट्यूड होना चाहिए, फॉलो अप होना चाहिए. ऐसा नहीं जा गया कुछ बोल दिया चल नहीं गया, तो फॉलो अप होना चाहिए. दे शुड बी इन्फॉर्म जी ये आपका काम है, ये ऐसे करना चाहिए. एंड strong emphasis on motivation. As I am telling again and again, the purpose is to support, to motivate, not to discourage and dissuade. So why Ashas need supportive supervision? क्यों चाहिए उनको? आशास का रोल मैंने बताया बहुत इम्पोर्टेंट ब्रिज है कम्युनिटी और हेल्थ सिस्टम. कम्युनिटी में जाते हैं, कम्युनिटी में लोगों के साथ रैपो बिल्ड करते हैं, उनका प्रॉब्लम्स देखते हैं, उनको सिकनेस समझते हैं, देन उनको लेके आते हैं. तो हमें बहुत सारे प्रोग्राम्स अभी आशा के ऊपर है, एंड आशा इंटरनेशनली एक्लेम्ड है, बिकॉज उनसे इतना इम्प्रूवमेंट्स हो रहा है, उनसे इतना काम कराया जा रहा है ना, अच्छा से हो रहा है. तो ये बड़ा इम्पोर्टेंट है हमारे लिए. बट फिर भी एज आई से देयर इज नीड फॉर सपोर्ट एंड सुपरविजन, both in my maternal child health, which was their originally expected role. Now it has grown into communicable other diseases. They have, I already described that institutional delivery, immunization, family planning, child health, newborn health, बहुत सारे रोल है. बट आगे जाने के लिए NMR, IMAN, इन सब के लिए उनको और भी थोड़ा सा गियर अप होने का जरूरत है. इसीलिए सपोर्ट और सुपरविजन जरूरत है, ताकि उनको सपोर्ट मिले, सुपरवाइज्ड हो, स्किल बढ़े और गाइडेंस, टाइमली गाइडेंस हो जाए. These are various roles which we are supposed, the supportive supervision for whom this handbook and this training will further be done. Our facilitators, ANMs, MPWs, CHOs. So all these are very important, pivots of health, and on which the full health system rotates. उनके ऊपर डिपेंडेंट है. तो उनको प्रॉपरली इन्वॉल्व करने के लिए और कैसे करना है सपोर्ट, कैसे सुपरवाइज करना है, उसके लिए ये हैंडबुक हेल्प करेंगे. Many personal problems होता है. Ashas, they are village level women. So इतने सारे programs है, इतने सारे उनसे expectation है. तो कैसे वो करे, कैसे वो properly करे, इसके लिए day to day में supervision चाहिए. आशास को कैसे सुपरवाइजर हेल्प कर सकते हैं? फैसिलिटेटर्स, ANMs, उनको नॉलेज दे दे. दैट इज वेरी इंपॉर्टेंट, बिकॉज उनको एक बार पढ़ाया गया मॉड्यूल्स और रिफ्रेश भी करा जाता है, बट फिर भी उनको ऑन फील्ड नॉलेज चाहिए. कोई किसी बच्चे का कुछ प्रॉब्लम है, कुछ है, तो उनको समझ आने के लिए उनको नॉलेज चाहिए, उनको स्किल चाहिए, उनको कैसे टेम्परेचर वगैरह मेजर करना है, कैसे वे करना है, सिंपल थिंग्स. ऑफन स्किल को बढ़ाने के लिए उनको सुपरवाइज होना चाहिए. एक बार मैं विजिट पे गई, तो एक रोल प्ले हो रहा था. तो आशा रोल प्ले कर रही थी. आशा के एक जन कर रहे थे, एक जन सुपरवाइजर का कर रहे थे, और एक जन मदर का कर रहे थे. तो वही है, मैंने जब देखा दैट हम इतनी पढ़ाते हैं, हाउ मच वी टीच देम ऑल दिस मॉड्यूल्स एंड ऑल, बट वो नहीं सिखाते हैं जो उसको सुनना है. First, they have to listen to the mother, because that is the most important part of counseling. उनको समझना, mothers को समझना. So that kind of skill, soft skills, communication skills, All these things need, supervision, and they will improve with hopefully with our supervisors. Report writing, recording में उनको मदद करना, regular visits करना, 30% of visits should be supervised visits, ताकि उनके कॉन्फिडेंस आए, आशा में कॉन्फिडेंस आए, और सुपरवाइजर्स भी उनको प्रॉपरली गाइड कर सके, उसका फीडबैक दे, जैसे मैंने बताया, अच्छा किया तो उसको मोटिवेट करे, अच्छा इतना नहीं कर रहे हैं तो उनको सिखाए, उनका स्किल नॉलेज इंप्रूव करे. देन ऑल्सो एरियाज pinpoint करे, because in field things are so very different. For someone something is needed, for someone something is needed. So on field supervision is very, very important. Mentoring, supervision, guiding, coordination, hand holding, all these are expected of our supervisors and facilitators, ANMs, NPWs and CHOs. Team के हिसाब से काम करे, so coordinate करे. So all these things are expected roles. So here is the handbook. Handbook आप पढ़ेंगे, handbook है मेरे पास. तो इसमें these are the various areas where we have highlighted what is supportive supervision, what are the key tasks, not only hand holding and visit during the visits, but also management, monitoring, record keeping, all these managerial tasks. Supervisors are great help in improving the program and success of the program. Various formats have been given, the kits have been mentioned. This handbook will help in monitoring and supervision in a proper way, because as I said, the checklists are very important for supervision. So this handbook will have, they will be help in having the checklist, the reporting and all the things at hand. So आज जो orientation हो रहा है, the orientation program is today. So this is half a day orientation we have planned, and further what is to be done is that those who are being oriented, they should take it to the next level, that is the block level. One day training should be there on this full handbook, because they will need more time, and as I said, their own skills need to be, the supervisor's own skills need to be improved, and they should be oriented towards the program. So during that orientation, this should be the main thing, that they know about the programs, they know what are to be done during the visits by the ushers, and how they can support the ushers. Then one day orientation of CHOs, ANMs, block nodal officers. After orientation of them, the actual CHOs, ANM, MPW, ushers, they can be trained for one day or half a day, half afternoon session for so that the whole thing, whichever is needed, is trained to them. Then reporting should improve by HBNC, HBYC. Supervisory format, that should be filled quarterly, and it should not be one-time exercise. Monthly, there should be review of the program, both the programs and supportive supervision activity. What comes out during all the meetings and all, that HBNC program, the reach is very good, but in many places the outcome, what should come out of it, that needs improvement, and we hope these supervisory activities and these initiatives will help that. HBYC program, again, the coverage itself now is again, it's not so much, so coverage must improve, as well as the training, as well as the rollout and quality visits during that, and reporting. So these are various issues which are bugging these two programs. So we really hope that our training, our orientation, our handbooks, and all our efforts from the center as well as from the state should be able to improve that. So thank you. We'll have interaction. You can have, I know, speaking one way is easier, but you also face a lot of problems, lot of this thing. So I would request that during the interactive session, some of your points which you are still need clarification can be discussed. So I am very thankful to my team as well as NHSRC team for organizing this, and let us make it happen. Thank you.
Thank you so much, ma'am, for your encouraging words and overview of our program, and setting a context for the supportive supervision. That is really helpful for us, and that would be really helpful for our state nodal officers and the nodal officer working at the district level. They will definitely will take up this your guidance, and will definitely improve the quality of our HBNC and HBYC program implementation. Now I would like to invite Dr. Maya ma'am, who is a master trainer associated with NSSRC. She will provide introduction to handbook of supportive supervision, which is meant for the our supervisors, ASA facilitator, A&M, and CHOs. And she will deliver the content of this handbook to our participants. Welcome, ma'am.
Thank you so much, Dr. Sharad. And before I start anything to do with my session, a big thank you to Dr. Smita Ghosh. I think you set a fantastic context. You've done quite a lot of my job. You made it easier for me. But I think that was an excellent start. And I'm also very happy to see that I cannot believe we have some 2,000 plus 2,500 plus participants. I've never ever seen such a large group online, and quite active, busy messaging and giving thumbs up. So they are active, and I hope you're going to continue to be active for the next few sessions, because like Dr. Sumita said, it's a constraint to train online, but we can make the best of it if it's as interactive as possible. So give me a chance to share my screen, and I hope, I'm going to find something in this whole thing. No, I don't want to share this. Just give me 1 second. Okay, so I hope you can see. Oh, no. So I'm going to go back and try. I need my file. Can you see this? Can you all see this? I can't hear anyone, so. Can you see my slides?
Yes, ma'am, we can see that.
Yeah, okay.
You can just.
Visible.
Thank you. All right. So before I start, I'm going to ask you quickly to use your chat and tell me at least 2 or 3 things that you learned from Dr. Sumita's session, because that's the context of going forward to understand what's in the handbook. So what did you learn? I'd like you to just quickly put on chat. Oh gosh, I don't know how to. Pankaj, you'll have to help me because I can't see my slides. Okay. So can you, in chat, tell me what did you learn? Only supportive supervision. There was a lot before that. Those are the last few slides with supportive supervision, but what was that before? Okay, so there are some points about supportive supervision, changing the attitudes of ASHA. But I think what you need to remember is the beginning, that why are we doing all this? We're doing this so that we want other children in our country to, first of all, live. You know, we don't want them dying before they're 1 year old, before they're 2 years old. I mean, look at your own children and your own families. I'm sure you would want your child to become an adult and a successful adult one day, and not only live, but live a good quality of life. Okay, so, and that's why you have these programs, and she talked about the HBNC and the HBYC. If you simplify, we're really talking about small little baby children, newborns and small children. If we can give them that foundation, just like any building, if the foundation is strong, then the building will last, much longer. So she explained to you why today we are struggling to keep our children alive. What are the causes? What are the problems being faced? So a lot of medical problems. And if you looked at those problems, why are these babies dying? Why are they sick? It's something that, many decades we have worked on, things that can be prevented. Malnutrition, okay, infections. They're not dying of some complicated medical, the situations. So there are some simple problems that don't seem to be going very fast. We have improved definitely over the years, and thanks to a lot of the government interventions and programs and all the work that you are doing. But we need to now press the accelerate button really fast, okay? And therefore, so we need to say, these are the issues. We have programs in place. And as a supervisor, as a person who wants to see things in my area improving, what can I do? Okay, and she explained that a lot of it is related to simple solutions. Okay, and that's what the handbook talks about. And so now I'm just going to quickly go through this handbook idea and tell you that for the next 40 minutes, I'm going to look at what is inside this handbook. It talks about what supportive supervision means, which Dr. Ghosh already kind of introduced it. Which are the areas under HBYC and HBNC that you need to focus on if you want to do supportive supervision? And then the people in the field who are really involved actively in supportive supervision, we know are the ASHA facilitator and the ANM or MPW. What exactly do we want? We can't just say supportive supervision and expect them to understand it. We have to, make it something that they can really follow. Okay.
Ma'am, may I request you, can you put it on?
Yeah.
That's very,
Okay.
thank you.
Correct. Okay, so let's start. I hope you have your handbook. If you have your handbook, please open it, because it'll make work easy for you, the soft copy. It talks about 4 different parts in this handbook, a simple handbook. What are the principles of supportive supervision? If I want to be a good ASHA facilitator doing supportive supervisions, I must know what the key work of the ASHA is so that I can help her and support her. And what is the role of the ASHA facilitator and the ANM in how does she support? What does she support? When does she support? Okay. And then it looks a little bit of program management. And finally, the tools that will help her to be a better supervisor. Okay, what we call the annexures, which will look at various tools used by the ASHA, which the facilitator needs to know about, the kits that Dr. Ghosh talked about that the ASHA can use. So what are these annexures? So through the day you're going to be hearing, I'm going to just quickly do this overview so that we can then focus on going forward and making it. This is just to talk about annexures, which are really important tools. And there's going to be a session later on which will explain these annexures to you. So you can see they're nothing, very confusing. CHOs, I can see, doctors, I can see, some PHC medical officers, you would have seen all these. You have the HBNC format, you have the ASHA kit checklist, you have the HBYC card, you have the medicine stock card, you have review formats for child death, and the checklist for home visits. Okay. One other tool that Dr. Ghosh talked about, and I really want to focus, emphasize, which I think single-handedly would be the most useful tool, is the MCP card. Okay, it's most useful not only for the mother, it's for the ASHA, facilitator. If we follow the new revised MCP card, which is so comprehensive, it'll help us not only be good supervisors, it'll help the ASHA to do her work, it'll help the mother to understand how she can bring up her child with the best quality of health. Okay. Now, going back to what Dr. Ghosh started with, what is this whole thing called supportive supervision? Said big words. Okay, there are some key things she mentioned, and that I want to re-emphasize. It's a facilitative approach. That means it's a helping approach, madad dena, okay, to supervision. It promotes mentorship, okay, a role model she talked about, okay, joint problem solving. Together we will do it. Teamwork, okay, and communication, which is so important. So these three things, how can I help? Okay, what kind of role model can I be? How can I work as a team of this group? Not I'm the ASHA facilitator and you are the ASHA, you listen to me. Okay. And how can I communicate in a way which is, first of all, clear? We talk about, communication being clear, complete, being correct, okay, being understood by the person we're talking to, not using big terms that they may not understand. The language, I'm sure I'm struggling with communicating to people who are largely non-English speaking, and I'm sorry about that, because unfortunately I don't speak other languages that well except Kannada and Tamil, because I'm from South India. But I want to re-emphasize the points Dr. Ghosh mentioned. Supervisors are role models. It's very difficult to be a role model, because today everyone's looking at them and seeing, okay, if you are a role model, you should be, if you're a good role model, you're a teacher, you're a mentor, you're an advisor, you're a listener, and you're someone I would be happy to share either my success or my problems. Okay, so this is what the profile of a good supervisor is. Not very easy to do, but it's possible. And we have to always keep on encouraging our supervisors, the ASHA facilitators, the ANMs and MPWs. If you can pick up this and be a role model, CHOs, you're an excellent example of a role model. People will come to you with problems, and then as a team you can solve. Basically, what do we want at the end of the day? We want a healthy community. We want our children to be happy, healthy, and live in a healthy situation. Okay. So, like I said, the handbook talks about these principles of supportive supervision. What is the principles? There are. One is it's respectful and non-authoritarian. When you say authoritarian, it is I'm the boss and you are the chela. So you listen to what I say, how I must say, what to do, I will tell you. You just keep quiet, listen and do. No, that's not supportive supervision. It's respecting everybody. Anybody, in mother, a child has an opinion. We have to respect it. They have an experience. We may not have gone through it. We have to listen and understand and respect it. Everyone is not the same from Jammu and Kashmir to Kerala. Okay, so we need to understand different situations. It requires you to be active. You can't sit like behind a computer and supervise. You need to do field visits. You have to do home visits. You have to have discussion meetings for the team to understand how we can figure out where are these areas that we can improve, whether it's a knowledge or a skill. Okay. It encourages two-way communication. I'm ready to listen and I'm ready to share. And open, not a yes, no. Tell me, is it this or that? Only answer yes or no. No, it's open. Everyone has some experience that they can share. they may need to share it in their own way. It looks at team approaches that can solve the problem. Remember, every person in this healthcare team, whether it is the ASHA, whether it is the Anganwadi worker, whether it is the ANM, MPW, whether it is the mother who is the center and the baby of the child, whether it is the PHC medical officer, whether it is your district trainers, district officers, you all are all part of the team who want to solve a problem. And each of you come with your own strengths. So everyone has to share that strength and share in the problem solving. Okay. And finally, it looks at, we need to know, and Dr. Ghosh started with the data. We cannot simply say, no, everyone's well. Unfortunately, in India, we are very happy to say, yeah, sab theek hai. How was the program? Nice. This thing, what did you learn? Sab kuch. These general things. No, look at the numbers. Now, the numbers in Kerala are very different from the numbers in Maharashtra or in Sikkim. Okay, the numbers within a district are maybe different. So, do we know that? The numbers in the village that I'm working at, or the sub center that I'm working in, or the health and wellness center I'm working in, may be different. I'm going to work with those numbers, but I must know my numbers. Okay. And then only I can say, for these numbers, this is my goal. And while I'm doing supportive supervision, I will look at how is this goal being achieved along the way. I'll regularly visit it. That's called monitoring. And using that data that I'm collecting, we're collecting so much data every day. We're uploading, filling records, filling reports, sending something online, offline. Sometimes we wonder, why are we wasting so much time? But if we can use that correctly, it'll help us get the job done. It'll help us support. It'll help us solve problems. It'll help us to then approach, when we go on our field visits with the ASHA and say, this is the problem. This is what we see. What can we do to make it different and better? So these are the 5 principles of supportive supervision, important for you to understand. And when you are doing your training, to explain it. Okay. So now, this is homework for you, and I'm going to ask you to put in the chat. There are some 7 things I've written. Which of these 7 are not supportive supervision? Come on, let me see. How many can give me ideas? Excellent, superb. I told you, this group is so active, but there are 2,000 of you, come on. So you can write it in Hindi, English, it doesn't matter, in whichever language. Oh, all are not supportive supervision. No. Then you're not reading. Very good. Some of you all have got the points. So that's excellent. Okay. So definitely blaming the ASHA is not. Okay. So these are definitely not supervision. Remember this, there's a saying we learn as children. If you point a finger at somebody, there are 3 more pointing back at you. So just pointing a finger and say, you only did bad, it's your fault, you are wrong. Actually, take some of the blame also. Shouting at the ASHA for not bringing the mother for immunization. What will it help? You'll only get a sore throat. Okay. Fault finding. This is wrong. That is wrong. You don't know how to do things. You're so silly. You can't. You're a stupid person, useless person, It doesn't help. But the other points, discussing, reviewing the form together, using the information that is seen in that MCP card or in HBYC card and saying, okay, let's decide what to do, and solving the problems. They are examples of supportive supervision. Okay. So remember, we want to support. And the green points here are the ones that are supportive. The red ones are not. So what do we want to support? Our goal is to support the team, to say, oh, wonderful, this is going so well. Always start with the positive thing. And then say, oh, but these are areas perhaps, we can improve. It looks like a gap. What is going wrong? Why is it going wrong? Okay. Support that. Don't police. Don't go there to the field and say, you are wrong. Criticize. Compare with somebody else. Look at that person is so good. You are using. Don't go checking. I've come here only to find out. Tell me 10 things that are wrong. Show me that. Where is the gap? No. Nobody's going to. That beautiful picture that Dr. Ghosh showed. As you enter, they'll all be running away from the back door. The next supportive thing is to assist that team. I've come with some skills. I've come with a little more experience, not more, or some experience. Hopefully, I can help you to look at the solution. The minute you list out a problem, never list out a problem without also listing out possible solutions. Not autocratic or bossy. Don't go with the attitude. I'm right, you are wrong. Or I'm the smart one, you are the stupid one. You go like that, you're not helping yourself, you're not helping the team, you're definitely not helping to improve infant and child mortality or morbidity. Okay. And use the tools and checklists that are provided because they're very supportive. Everything cannot be in everybody's head. They are meant, they've been developed so that it can make our work easy. So use it. It's proof. It is a support kind of a tool that will help us to remember things and not forget key important things. So remember these few points that will help you to really do good supportive supervision. Now that's general. Let's look at HBNC first, and then we look at HBYC. What is the supervision required? Before we answer that, who does it? Usually it's the ASHA facilitator or the MPW. Okay. When do they do this? Anyone can answer again in chat? When can they do all this supervision for HBYC? So remember we said they can do it during very good after home visits, field visits, excellent joint visits. Excellent. My goodness, this team is too good, man. So that's the time when they can do it. So, and finally, who are they supervising? They're supervising the ashas, and sometimes we forget about the other frontline workers. Okay, sometimes the Anganwadi worker helps the ashas a lot. The ANMs are there in the field. Okay, we have other VHSNC members. There are a lot of other people who also can help be supervised when you do your field and home visits. Okay, so what are the key tasks that they need to do? There are 9 tasks. Okay, so the first one is before you do anything as a supervisor, you plan. Plan the visit. You cannot just go on only on surprise visits. Okay, the ASHA may be busy with something else. So make sure you plan and try and make sure you cover all the ASHAs. You have many ASHAs. A facilitator has sometimes 20 ASHAs. So how can she cover all of them? Whether she doesn't have to do field visits for all of them. Maybe sometimes in a meeting, maybe 10 of them she'll do this month and 10 in another month during field visits. Okay. Focus on the new ASHAs who may need more supervision, on places where ashas have a lot more newborns and pregnant women or sick children. And that brings us to our second point: prioritize. Prioritize places where there are homes with high risk mothers, high risk children, where there's a home and Asha says, how many times I've visited, but they do not listen, they don't follow up. I don't know what to do, how to convince them. Okay. Don't forget homes that are marginalized groups, disabled, settlements, in far a little away from the village. Remember all that. Okay, reaching the unreached. Okay. Then, once you have planned and prioritized, you then do joint visits. Okay, and when you do joint visits, again try and focus on homes where there's complication, so that you can also double up and give a solution. Homes which Asha may not have had time to visit, so you go with her and say, okay, that time you couldn't go, I'll come with you, let's go. Or to observe her, how she's doing things, so that you can come back and then talk to her and review. And remember, when you're training your supervisors, never correct an ASHA worker or a person in the home in front of someone else. It's very disrespectful. Then bring them outside and explain. The next point is to gather the correct information. Look at the reports, look at the MCP cards, look at the monthly reports. How many deaths, how many illnesses, okay? So you have the information. Now, the other points are, in order for the ASHA to do work effectively, she has a kit, she has some cards, she has some supplies of medicines. Does she have enough of it? Is it available? Are the job aids and checklists available with her? Okay, so that when during this can be done during the monthly meetings you have with the ASHAs. Make sure the referral service is available. All children cannot be treated at home. Some children are referred, but ASHA must know for this village, where is the referral place? It may not be the nearest PHC or the nearest sub-center for dangerous situations. A sick newborn, you want to send directly to the district hospital or an FRU where there's a sick newborn unit. Okay, so it's like a little map that can be made. Okay, for this ASHA, these are the referral areas. So strengthen that, build it up. Contact the referral person and say, ASHAs from my area may contact you. Please support them. Okay, it requires follow-up. After the referral doesn't think my work is over, what happened? When they come back, they're going to come back to you. Okay, when we talk about comprehensive PHC, we talk about this continuum of care, and follow-up is a huge part, which is a big gap in India. So follow-up is really important. They're coming back to the field, to the ASHA, to her community. So the referral service is not only upwards, it's also backwards, okay, down. Build a community. ASHA is not working alone. There are VHSNCs or MAS in the urban area. There are interested mothers. There are role model mothers. There are some panchayat members or individuals who might volunteer their time. Okay, there's Anganwadi workers. So school teachers who are interested and can help you with the small children. So build that community support and say, okay, can you help the ASHA with this area? We have SH Sanghas everywhere. They're a huge support. Okay. Finally, meetings. Conduct your meetings not only because you're going to get asked for this thing, but conduct it because it's a chance to discuss, to share, to go through what has happened, and then where are the gaps and how can we plan for the next month. It could be during the monthly meeting when you're doing at cluster level. It could be the monthly meeting at the sub-center level that you have. And of course, the other task is the payment and grievance redressal, which is the role of the ASHA facilitator and the ANM. Okay, if grievances come, what will you do? Now, I want to talk about specific role, which is slightly different sometimes between the ASHA facilitator and the ANM. I have put in bold for the first one in a household visit. If it's the ASHA facilitator, she will be making sure that all the pregnant women, all the newborn babies are covered. It's not only this group or that group or this area, and they're leaving out, one settlement far away. Okay, and she will identify gaps. But look at the ANM. The ANM will also look at the technical part because she has a little more skills in that area. She'll give more feedback about the accuracy of the advice given, what referral decision needs to be taken. And because of her experience and skills, she may be actually able to provide care, which the ASHA facilitator may not be able to do. Okay. Now, look at the second point and you tell me what is the key point that is different from the ASHA facilitator. The second point is the same. They'll support the process of replenishment. But in the first point, what is different between the ASHA facilitator and the ANM? So back again to chat. Come on, come on. Just in point form. Under ensuring supplies. ensuring logistics and supplies. So it's written in ASHA facilitator, collect and submit information about availability. And in A&M, it's saying support the replenishment by providing the medicines whenever feasible. So according to you, what is the differences? Good, you're getting the idea that the additional work that the A&M or the MPW will do is more technical. Okay, so here are some more things to show you. Okay, support the payment process. You know, the ASHAs are paid on a incentive basis besides on a fixed thing. So the ASHA facilitator will review and verify the vouchers, okay, and submit them upwards to wherever she has to submit. The A&M will definitely also do that, but she'll also keep a record of the service. So you can see this is slightly extra compared to what and it has to match with the MCP card. Okay. So these are things again, which is technical that she will look at. Okay? And she will also sign. Grievance redressal is mainly the ASHA facilitator because she will see, she's working much closer with the ASHAs with this. In death reporting, the ASHA facilitator largely is collecting it. Okay, she may have a little bit of discussion, but she'll have to discuss with the A&M to find out a little more technical information. The A&M can do more joint visits to actually understand and the cause of the death, the reason, and also how can we move forward and prevent such things. If it comes to the VHSNC, the ASHA facilitator will look at the meetings, what's happening, the regularity. The A&M can attend these meetings and give trainings, technical information, and more support. And actually even provide services during the VHND that, she can do a lot more health care support. Okay. So I hope you're understanding what I'm explaining. When it comes to referrals, okay, the ASHA facilitator will motivate the ASHAs, okay, convince the families to go. Very few families, many families say, no, we don't want to leave the village and go far away. We don't know where to go or how much it will cost. But sometimes the need is important for the child. So how to work with them, how to convince them. The A&M will also support this, but you can also say, does this child really need referral? Okay. And can I initiate some treatment in case there's a delay in the ambulance coming or in the delay of transport? So it's slightly more technical. Monthly cluster meetings. The ASHA facilitator will conduct the meetings. The A&M can be brought in for helping what is the correct solution for these problems. Okay. During PHC medical, it's the same situation where the ASHA facilitator will ensure that ASHAs attend the meeting along with her, whereas the A&M will give more technical inputs, whether it is from the reports or not. So you can see that each one has a role. Some roles are overlapping and same, but some roles are more technical. So when we also train, we should say, use your skill. I told you in the team, each one has their own strength. My strength is into, supporting, holding the hand, talking nicely as an ASHA facilitator, getting things done. As an A&M, I'll do all that, but I can also train. I can do some skills training. I can check and see that these entries are correct. Okay, if the weight has to be written or the blood pressure measurement, all these little more technical things I can do. Okay, so I have finished my talk very, very fast because the rest of it you can read. All of y'all can read. I don't have to explain to you. HBYC, and before I go to the last slide, I want to ask you again, what is the difference between HBNC and HBYC? Come on, let me see how many you will list. Let's start with HBNC. What is the focus in HBNC? Quickly. I want to give you time to just, I hope you'll all have some water to drink. And, if you're sitting down, you can stand up and just stretch a little bit. Okay, neonatal. Okay, mother and child. Yeah, both are for mother and child. The first 42 days, excellent. Very good. Yeah. Okay. So the focus is on neonatal because we know the deaths are more. Okay. And the problems are more focused in that area and more immediate. Okay. Okay. Good. HBYC, what is the difference? Yes. Okay. Up to 15 months. You don't go that often compared to, but you go every 3 months. Okay. I have to congratulate this team. They're really active. Okay. Yes. Okay. Okay, now tell me what is common between the two. You've told me the differences. Excellent, excellent, excellent. Okay. Common things. Feeding, yes, feeding. In HBNC, you worry about breastfeeding. In HBYC, besides breastfeeding, you have to think of complementary feeding. Because nutrition, malnutrition is the underlying problem in our children. Remember that, okay? The second common thing is immunization. Fantastic, excellent. It's in both groups. Infection prevention. You want to prevent infection of a newborn baby when it's sepsis, which is so dangerous. You definitely want to prevent diarrheas and pneumonias and all these 101 things, including COVID in the children. Okay, excellent. So I'm glad no one's sleeping. Everyone's wide awake. Growth monitoring, which you do in both. Good, good, good. So you do know the focus areas. Okay. So as a supportive supervisor, our focus is on how can this ASHA facilitator, 4Ds, someone's mentioned the 4Ds. That's okay. That comes mainly in HBYC because it's slightly older child looking at the, the 4Ds. And I hope you will read up 4Ds in case you identify. Oh goodness, I'm so proud of all of you. Anyway, so let me conclude by saying that in supportive supervision, you need to be a role model to your team. Okay, because behind that, what do you want to do? You want to assist them, you want to help, you want to help solve problems, you want to do it in a way which is acceptable, friendly, respectful. Okay, and you want, finally, both of you, all of you in that team want healthy babies, healthy children in your community. It should be like a competition. The CHO must say, my sub-center area, there will be no neonatal deaths, there will be no infant deaths. I will see that malnutrition is reduced to the maximum extent. And as a child health specialist, I want to say, don't only look at SAM. Moderate malnutrition is much, much bigger and easier to handle and manage. If we can push them from moderate to healthy, which is so much easier, don't forget that group. Okay. So supportive supervision is a helping attitude, a regular, difficult, so easy to go and be a policeman and say, ah, you're useless, this is bad, go. I went for a visit, come back and curse. But to go in and home visit, sit down with the team, chat, explain, read up, look at the information, lot of hard work. But in the end, the satisfaction is so much more. Okay. And when we are doing supportive supervision, we should ask ourselves, who are we doing it for? What are we doing it? How often do we do it? When do we do it? Okay. Don't forget those. It's not 4 principles, but 5 principles. Okay. And those 9 key tasks, starting from planning to prioritizing, okay, to actually going to the field, visiting, gathering information that's required, making sure that the supplies, the job aids, the checklists are available for that ASHA workers to be able to do her work well, okay, to conducting meetings, to listening to grievances and getting them addressed, and to making sure that their payments come. Some of the administrative duties you can't do, but you can communicate the problems that they are facing. And with that, I'm going to say thank you to this fantastic group and go back to the session where I will stop sharing my slides and hand it over back to Dr. Sharad Singh. I do hope it was useful. And remember, whatever I've said is written in that handbook, and you can go through it slowly, but do go through it from one end, beginning to the end, because that will help you when you are training and going further down the line. Thank you very much.
Thank you so much, ma'am, for your, I think, enriched experience in training, and you have nicely articulated and delivered this session. And I hope the district level nodal officers, even at the state level nodal officer, they are quite sure that they could understand all these content related to supportive supervision in an interactive way. We can also see in the chat there are a lot of interaction in between. So we are happy to see that interaction with the district level officials also. So big clap to you, ma'am. Thank you so much for your time. And we request you be present during the entire course of so that your valuable input would be very appreciable and will be helpful for our participants who are here to attend this workshop, orientation meeting. Okay. So I have given this responsibility by my colleague who's a very hard worker, Sumitra ji. She used to provide me a lot of responsibilities to deliver these things, but I requested to her to deliver this session. But let me just explain about the program management and monitoring of HBYC and HBNC program. So if you have gone through this supportive supervision handbook, all the participants who are attending this, they could able to see the section number 3. It has written in the that the program management and monitoring related to HBNC and HBYC program. We have since we are implementing this program HBNC since 2011, and the home visits was started in 2012 and 13 onwards, and this program has quite matured enough and have a great potentials. Everyone knows that, and we are assessing the progress of implementation in the states and particularly in the district also, because we are collecting information district wise, and we used to give feedback to our state nodal officers, particularly related to data quality, the completeness. Sometimes we found that there are data discrepancies in some of the districts, like the live bus in ASA catchment area sometimes is less than, and home visits is more than in the some of the districts. There could be a data assimilation or compilation issues. So my request to state nodal officer and district nodal officer to please see the quarterly progress report which are being submitted from the blog and further submitted to the state, so that we can rectify this data error at their level, and we can improve our data qualities. So let's come to the please next. We all know that this program HBNC and HBYC is a joint program, is being managed by both the child health and ASHA nodal officer, not at the state level, at the district level, even at the block level also. It's a joint effort to be done. At central level, you can see we are here, NSRC team is there, our team is here. So we are in a close coordination with this program for implementation. So my request to district nodal officials, so definitely they should also speak to our child health program officer at the district level and give the feedback to them also for further improvement. And for further skill enrichment or skill retention program also that can be done at the district level. And I would like to just emphasize here that our state of Uttarakhand now gone ahead, they are doing a refresher training for HBYC program. So some of the states are in the just initiation of training, but they have gone ahead. They started refresher training, and they are doing. So I'll be also visiting to see that refresher training, what the content they are delivering, how it is important, and what is the need of refresher training right now, and the content which can also be replicated to different other states and UTs if required, when they will saturate their training and they will implement the program further. So in the program management of HBNC and HBYC, definitely we need to look all these challenges and good practices, and that should be discussed even at the block level. At the district level, I know that lot of work pressure at the block level. Even ASHA has given a lot of responsibilities or different program even in NCD and other program also. So, but MCH, Mother and Child Health program is also equally important. So, we request to district level officials, they should also review this program and see the data quality, give the feedback to block level nodal officials to rectify them at there, and then the regular compilation and submission of report to the national level. I found that there is a lot of delay in QPR submission. Some states are submitting in maybe 1 month, 1.5 months later than after completion of the quarter. So my request is to all the even district level nodal officers, they should submit their report on time to state so that they can further submit this in, QPR to our national team. So you can see next, please. Next. These slides are already covered by Maya ma'am. So I would like to highlight that there are some key indicators for this program managers. You can see for the HBNC at the district level or district nodal officer, they can assess their progress of the program. They can assess through these indicators like percentage of us are trained in the all 4 rounds of HBNC. You all know that HBNC home visit could be started once the module 6 and 7 training completed of 3rd round. Once ASA is trained in 3rd round, they should start the home visits. Okay, so also one of the most important element is the HBNC kit. Without kit, we found even in morning session, Dr. Shumta was also explained that during our field visit, most of the time we found that all items in the HBNC kit are not available with the ASHA. So my request to all the state level nodal officials and district level nodal officers, the timely replenishment of HBNC kit should be done so that their visit should be in a qualitative. So next indicator, you can see the number of newborns visited against the live births, and this live births is in the ASA catchment area. We also found that while analyzing this data through denominator through HMIL, there are huge gap in it. And so our coverage is also at the lower level. So recently with approval of competent authority, we decided to revise our QPR, HBNC QPR. In there, we now collecting information for the live bus in ASA catchment area. That will give the real pictures for, because this HBNC program is the incentive-based program and is being implemented by the ASHA. So the live bus in ASA catchment area would be the denominator for that. Okay. You can see the percentage of newborn visited on day 1 in case of home delivery. That can also be seen. Number of newborns received, percentage of newborn received complete schedule of home visits in case of home deliveries, in case of institutional delivery, and last one is the referral. So high risk newborn referred to further treatment at the nearest health facilities. So these are the quick indicators we can see for the HBNC program. For HBYC program, the percentage of young children visited by ASHAs, percentage of young children who were sick, LBW as newborn visited by the ASHAs, young children identified with development delays, young children identified with sickness and referred to nearest health facility. These are the quick indicators we can assess for the program progress. But apart from that, there are other indicators in QPR. Every nodal officer at the district level, even at the state level, they are well aware about the indicators of the QPR. So no need to emphasize it. But my request is to review this data set at your level, at block level, at district level, so that the mid-course correction or correction can be done at there only. Please, next please. These are the numerator and denominator of the same indicators which we have already provided, and you can see that in the section 3 it is already given that the indicators, the proportion of newborn visited by ASAs, proportion of newborn visited on the first day of birth as in case of home deliveries, the same indicator which we have already mentioned. Next please. In HBYC you can also see that the proportion of young children visited by ASAs and other indicators which we have already mentioned in the last. Next please. So what we expect from the our supervisors to make a home visits along with the ASAs as a supportive visits, and they should handhold at their side. And these are the formats which we have developed, and these are being used basically in quite some time. And ASAs are well aware, even our ASA facilitator and supervisor are also well aware. The purpose is here to demonstrate, to just re-emphasize it, so that most of the things we may forget it. Most of the things we could not find it in the field also, like the completeness of data recording in MCP card. And so I visited several states and even CRM also, we found that ASA knows everything and on fingertip, but they could not able to mention in the MCP card. And even mother and beneficiary, they are not aware about this information. So this information should also be transmitted in the communities and by ASA, and time to time it should be emphasized by our supervisor also. So I would like to invite my colleague Sumitra ji to deliberate on these formats so that everyone should understand the need of these formats and content of the formats. Please. I'll
A very good afternoon to all of you. I am Sumitra, working as a senior consultant with the Child Health Division. So thank you, Saraji, for handing over this session to me. This is section 4 of the HBYC Supportive Supervision Handbook for ASA Facilitator, ANM, and MPW on HBNC and HBYC. So if you have the handbook, please open it and you can have a look at all these checklists, all these annexures, formats, and kits. So this particular section is having 7 different annexures. And out of 7 different annexures, this is relating to HBNC recording format, HBYC recording format, HBNC kit, HBYC kit, and also the checklist for the supervisor, ताकि जब supervisor फील्ड जाए तो checklist को देखे कि क्या करना है. And at the same time, there is a reporting format for supportive supervision, जो कि हम नंबर 7 annexures में है. तो to start with, this is annexure 1. मैं ये कोई भी नई बात नहीं बोल रही हूँ, ये सारा आप लोग यूज कर रहे हैं डे टू डे फील्ड विजिट में ड्यूरिंग HBNC होम विजिट. तो ये जो फॉर्मेट है,
सॉरी ये शेयर नहीं हो रहा है.
ओके, हम अभी कैन वी ओके लेट अस शेयर दिस annexures. Let's go through this section 4 list of annexures. Yes, is this visible? Is the annexure visible?
Yes, yes, visible.
Okay, thank you. So I'm sure आप लोग ये
अपना वो बंद करो.
okay. There are some technical glitch. क्लिक कर दीजिए, ऑटोमेटिक चले जाएगा. बाहर क्लिक कर दीजिए. क्लिक कर दीजिए.
Stop it.
I think if you can put the annexure on the chat box, then people can open it and listen. It was put earlier. Someone can redo it, then they can open it, and then you can use your PPT to explain.
No, it is.
बाहर क्लिक. हाँ.
Yeah.
Okay, so is it visible now, ma'am? Is it visible?
Yes, yes.
Okay, so let's go through this annexure, and we'll not go through in detail one by one, because we all are using at the field for HBNC home visit. With the interest of time, we'll just go through it. So the first 1A that we have this particular HBNC recording card. This is for mother and newborn home visit that ASA used to fill. So this is the supervisor's job to see whether ASA is filling each and every field or not. So coming to the annexure 1B, that is relating to the day one recording by the ASA, when the ASA will visit to the home visit, ASA home visit first 1 hour after the birth. And here the most importantly we have to see, as a facilitator, for ASA facilitator हो या फिर ANM MPW, जब भी फील्ड में सुपरवाइजर विजिट के लिए जा रहे हैं, उनको ये देखना है कि ASA ऑल द फील्ड को, ईच एंड एवरी फील्ड को जहां पे रिक्वायरमेंट है उसे फील कर रही है एंड करेक्टली फील कर रही है. कंप्लीट फील्ड एंड करेक्ट फील्ड, एंड इसको प्रॉपरली रिपोर्ट कर रही है जो भी है, क्योंकि इसमें बहुत डिटेल में दिया गया है. तो आशा के लिए ये चेकलिस्ट भी है एंड आशा के पास ये सारे इंफॉर्मेशन अवेलेबल है. आशा को ये देखना है कि अपना जो ट्रेनिंग है, अपना जो उसने आशा जो ट्रेनिंग में उसको मिला हुआ है, उसका जो नॉलेज है, इसको इस्तेमाल करते हुए ये ईच एंड एवरी फील्ड को आशा को फील करना चाहिए, जिसको सपोर्टिव सुपरविजन के दौरान आशा फैसिलिटेटर को ये देखना चाहिए कि ये करेक्टली फील हुई है कि नहीं एंड कंप्लीट फील हुई है कि नहीं. दिस इज मोस्ट इंपॉर्टेंट, एंड द इंफॉर्मेशन जो दिया जा रहा है वो करेक्ट है. नेक्स्ट कमिंग टू एनेक्चर 1C, जो डे वाइज है. एनेक्चर 1C डे 1 to डे 42 डेज के अलग अलग सेक्शन में हम उसको देख सकते हैं। आशा जब भी फील्ड विजिट करे तो माँ को पूछती है आशा बच्चे के बारे में, माँ के हेल्थ के बारे में, एग्जामिन मदर का भी एग्जामिन होती है उसमें, एंड इसमें कुछ एक्शंस आशा लिया है कि नहीं लिया है, ये राइट साइड में आपको दिखाया जा रहा है। मैं अपना फील्ड एक्सपीरियंस शेयर करूंगी। जब हम फील्ड में जाते हैं हम मोस्टली ये देखते हैं कि ये जो HBNC होम विजिट जो फॉर्मेट है, आइदर वो हाफ हजार्डली फील है या फिर कुछ जगह पे आप देखेंगे कि प्रॉपरली उसको फील नहीं किया गया है। अगर 42 डेज तक फील्ड में जाना है एंड एवरी विजिट में इसको एज पर द विजिट फील करना है पर्टिकुलर फॉर्म को, तो आशा कभी कभी ऐसे करती है कि घर में पूरा जाती नहीं है, फुल टाइम उसके साथ बैठती नहीं है, उसको फील करने के लिए जो रिक्वायरमेंट है समय और इंफॉर्मेशन आशा के पास होती नहीं है। समटाइम्स 21 डेज या 14 डेज में भी हम देखे हैं कुछ फॉर्मेट ऐसे होते हैं जो 42 डेज तक प्री फिल हो चुकी है। तो आशा सुपरवाइजर का ये बहुत बड़ा रोल है ये देखने के लिए कि एवरी फील्ड should be filled properly, and as for the home visit, if ASA is going on 7th day, then ASA should fill on the 7th day information, not for the 14th day, not for the 21st day, or pre-fill for the 28th or 42 days. This is very important for every, क्योंकि आशा को each visit के लिए इंसेंटिव दिया जाती है और आशा को जाना है। इसका इंपॉर्टेंस जो है डॉक्टर घोष मैडम एंड माया मैडम का प्रेजेंटेशन में बताया गया है क्यों जरूरी है। एवरी होम विजिट इज इम्पोर्टेंट। एवरी डे 1 to day 42 का जो 6 और 7 विजिट, एवरी विजिट इज इम्पोर्टेंट टू रिड्यूस द चाइल्ड मॉर्बिडिटी मोर्टालिटी, एंड इसके लिए कुछ एक्शंस लिखा गया है। एंड सुपरवाइजर का बहुत बड़ा इम्पोर्टेंट रोल है यहाँ पर टू सी कि आशा इज हैविंग द प्रॉपर नॉलेज, आशा इज हैविंग द प्रॉपर स्किल, आशा इज हैविंग द प्रॉपर tool to fill this, so that the identification of sick child, identification of any issues can be done in time, referral could be done in time, and supportive supervision could be done properly. And this is the highly required. Next, we have to go to the next page. So there is a supervisor note. We can see in the right side, this format is very important. Each and every state is using this format in their own language, but this need to be filled properly, correctly, and completely. The information should be written, informed properly. This is the most important part for the supervisor to see, which is actually not done or very partially done or very limited. This needs to be strengthened. Some states are really doing good, some supervisors are really doing good, but we need to strengthen to reach to the 100% correct information. Because why information is required, definitely Maya madam has already mentioned during her presentation. So next is the Annexure 2. This is relating to the ASA kit. This has been discussed during Dr. Ghosh madam's presentation and Dr. Maya madam's presentation, but still why this is important here from the supervisor's perspective, that she need to see this particular ASA kit has to be there with the ASA when ASA is in the field. That should be functional, which is most important. Many times this is not functional. Either ASA is not carrying this to the field. ASA field को बहुत समय पे लेके जाती नहीं है, या फिर एक छोटी सी किट लेके जाती है जिसमें थोड़ी सी गज है या मेडिसिन है, कुछ छोटे छोटे चीज होती है, या ओनली डिजिटल थर्मोमीटर होती है। मोस्ट ऑफ टाइम हम देखते हैं जो वेइंग स्केल विथ स्लिंग जो है वो ऐसे ही फोल्ड होके रहती है। तो ये जो ब्लैंकेट, बेबी ब्लैंकेट लेके नहीं जाते हैं। तो हमें ये कोशिश करना है आशा सुपरवाइजर, ANM, MPW, CHO के माध्यम से ये देखे कि आशा के पास ये किट अवेलेबल है, फंक्शनल है, एंड आशा इसको यूज कर रही है प्रॉपर वे में। आशा के पास ये स्किल है कि इसको प्रॉपरली यूज करे। दिस इज द मोस्ट इंपॉर्टेंट पार्ट फॉर ए सुपरवाइजर। एंड ये स्टेट ऑफिशियल का ये स्टेट ऑफिशियल पॉइंट ऑफ व्यू से ये देखना है कि दिस इज सप्लाइड टू आशा एंड this is replenishment is also happening as per the due course. Next is HBYC kit for ASA. So this is similarly, there are some basic kit. There are some particular materials like 15 different materials that state has to supply to the ASAs, and ASA should use this in a proper manner. I hope कि जब आशा का ट्रेनिंग हुआ है, ECD का ट्रेनिंग हुई है, तो आशा ट्रेनिंग में, HBYC ट्रेनिंग में आशा को इस पर्टिकुलर HBYC किट के बारे में प्रॉपरली ट्रेनिंग दिया गया है। एंड रेगुलरली आशा सुपरवाइजर, ANM, MPW and CHO, whenever they will do the supportive supervision visit, they can support them. If ASA is still lacking any skill, ASA is still lacking any related information, if ASA is not doing the proper use of this particular kit. So ये सबसे बड़ी इम्पोर्टेंट चीज है कि आशा सुपरवाइजर के पॉइंट ऑफ व्यू से कि ये देखना है कि HBYC किट आशा के पास हो, उसका प्रॉपर इस्तेमाल हो, आशा को इसके बारे में, इसका स्किल के बारे में आशा को पता हो कि कैसे इस्तेमाल किया जाता है। तो थोड़ी सी टाइम दे, जो परिवार में जा रहे हैं, HBYC का जो बच्चे हैं 3 मंथ्स से 15 मंथ्स की जो बच्चे हैं, उनके परिवार में जाते हुए इसको इस्तेमाल करते हुए MCP कार्ड में वो दिया गया है। आशा हैंडबुक के अलावा जो MCP कार्ड में इसका डिटेल है, हाउ टू यूज इट, और इसके माध्यम से ये देखे कि कोई डेंजर साइन है क्या, पेरेंट्स को कैसे काउंसलिंग किया जाए, एंड अगर कोई डेवलपमेंटल डिले है, कोई इशू है, कोई डेंजर साइन है, तो इसे रेफर किया जाए ताकि हम अर्ली रेफरल हो एंड बच्चे को बेटर ट्रीटमेंट और बच्चे को जो भी सपोर्ट हो सिस्टम से मिल पाए। नेक्स्ट we'll go to Annexure 3, which is a HBYC होम विजिट रिकॉर्डिंग फॉर्मेट। अभी तक जैसे ऑलमोस्ट 450 डिस्ट्रिक्ट्स में हो रही है HBYC विजिट। आई एम श्योर कि उस सब डिस्ट्रिक्ट्स में ये पर्टिकुलर फॉर्मेट को यूज किया जा रहा है, एंड दिस पर्टिकुलर फॉर्मेट रिवाइज्ड MCP कार्ड में ऑलरेडी मेंशन्ड है पेज नंबर 8 में। तो आशा सुपरवाइजर का यहाँ पे बहुत बड़ी रोल होती है कि देखे कि प्रॉपरली आशा को ईच एंड एवरी जो पॉइंट्स है, क्या चाइल्ड सिक है, क्या चाइल्ड प्रॉपरली ब्रेस्ट फीडिंग एंड कॉम्प्लीमेंट्री फीडिंग ले रहा है, क्या चाइल्ड अंडरवेट है, वेदर इट इज ए रेड, वेदर इट इज ए येलो कैटेगरी, क्या बच्चे को ORS मिल रही है, IFA सिरप मिल रही है, या बच्चे को अगर बच्चे को इम्यूनाइजेशन प्रॉपरली दिया जा रहा है कि नहीं। ईच एंड एवरी पॉइंट इस पर्टिकुलर फॉर्मेट में मौजूद है। और आशा का जब भी आशा को, अगर आशा का कहीं भी प्रॉब्लम आ रही है, तो सपोर्टिव सुपरविजन में, हैंड होल्डिंग में आशा फैसिलिटेटर को इसको फिर से एक्सप्लेन करना चाहिए, आशा के लिए उसको काउंसलिंग करना चाहिए, दिखाना चाहिए, कहीं जरूरत पड़े तो आशा फैसिलिटेटर को, ANM को दिखाना चाहिए कि कैसे फील करते हैं और किस तरह से प्रॉपरली इसे फील हो, एंड ताकि अगर ये फील प्रॉपरली हो 3 मंथ्स टू 15 मंथ्स के बच्चे के लिए, देन आपका डिस्ट्रिक्ट रिपोर्टिंग में प्रॉपरली ये रिफ्लेक्ट होगी डाटा में। देन नेशनल लेवल पे डाटा जो आती है तो इसमें प्रॉपरली रिफ्लेक्ट हो सकती है, क्योंकि हम समटाइम्स ये देखते हैं कि जितना बच्चे हैं उससे ज्यादा बच्चे को रेफर किया गया है। दैट मीन्स समटाइम्स हम प्रॉपरली फील नहीं कर रहे हैं, हम जो भी नंबर आती है हम उसको फील कर रहे हैं। तो डाटा जब एग्रीगेट होती है, जब कंपाइल होती है, तो उसमें डाटा रेड कैटेगरी में चली जाती है। तो हमारे लिए ये बहुत इंपॉर्टेंट है कि आशा फैसिलिटेटर देखे कि प्रॉपरली विजिट हो रहा है 3 मंथ्स चाइल्ड को। जहां हम क्रॉस दिए हैं तो 3 मंथ्स चाइल्ड को जरूरत नहीं है या 6 मंथ्स, तो ये एज अप्रोप्रिएट बॉक्स ओपन किया गया है और लॉक किया गया है। तो इसको समझना बहुत जरूरी है। समटाइम्स कॉम्प्लीमेंट्री फीडिंग में भी हम 3 मंथ्स में भी कुछ डाटा हमें मिल रही है। दैट मीन्स आइदर आशा इसको अंडरस्टैंड नहीं किया है या फिर डाटा जो कंपाइल हुआ है जिस लेवल पे भी, सुपरवाइजर लेवल पे, तो वहां पे भी इसका अंडरस्टैंडिंग का इश्यूज है। तो इम्पोर्टेंट ये है कि हमें ये अंडरस्टैंड करना है कि व्हाई ये क्रॉस दिया गया है, क्यों क्रॉस हुआ है, क्योंकि उस पर्टिकुलर एज ग्रुप में ये जरूरत नहीं है। 3 मंथ्स में कॉम्प्लीमेंट्री फीडिंग का जरूरत नहीं है, इसलिए इसको क्रॉस किया गया है। So, being a ASA facilitator, being a ANM, MPW or CHO, as the case may be, as per the state or UT, तो हमें ये देखना है और accordingly proper form filling and data capturing requirement है। नहीं तो हम क्या काम कर रहे हैं ये रिफ्लेक्ट नहीं होती है, ओनली डाटा के माध्यम से रिफ्लेक्ट हो रही है। Going ahead, Annexure 4, तो उसमें इक्विपमेंट एंड मेडिसिन का स्टॉक कार्ड है। आई एम श्योर कि आप लोग ये जरूर कर रहे होंगे, जो अवेलेबल फंक्शनैलिटी का एस्पेक्ट एंड रिप्लेनिशमेंट का जो रिक्वायरमेंट है आप लोग इसको जरूर भर रहे होंगे। तो आई एम नॉट गो बाय डिटेल, बट दिस एज ए सुपरवाइजर, बिकॉज दिस इज फॉर द सुपरवाइजर एंड आशा ऑल्सो, तो सुपरवाइजर को ये देखना है कि आशा के पास ये फॉर्म अवेलेबल है, आशा इसे इस्तेमाल कर रही है एंड सुपरवाइजर इसको अपवर्ड डायरेक्शन में इसको सबमिट कर रहे हैं ताकि रिप्लेनिशमेंट टाइमली हो, आशा के पास अवेलेबल हो। नेक्स्ट इज हम आवर CDR फॉर्मेट, जो कम्युनिटी बेस्ड CDR होती है, चाइल्ड डेथ रिव्यू होती है, उसका 2 फॉर्मेट है। आई एम श्योर आप लोग सब यूज कर रहे होंगे, बिकॉज CDR का चाइल्ड डेथ रिव्यू का जो प्रोग्राम है वो भी चल रही है हर किसी स्टेट में। एंड आशा के पॉइंट ऑफ व्यू से नोटिफिकेशन कार्ड इज वेरी इंपॉर्टेंट। आशा का ये इंपॉर्टेंट है कि आशा नोटिफाई करे। एंड देन Form 2, which is a first investigation report that need to be filled by ANM or MPW, so that community based जो CDR है उसका एनालिसिस हो पाए और ये डिटेल रिपोर्टिंग हो पाए। एंड ये ऐसा सुपरवाइजर के पॉइंट ऑफ व्यू से मोस्ट इम्पोर्टेंट चीज ये है कि ये फॉर्मेट आशा के पास अवेलेबल है एंड ईच डेथ केसेस शुड बी रिपोर्टेड ऑन टाइम एंड फर्स्ट ब्रीफ इन्वेस्टिगेशन रिपोर्ट शुड बी देयर। नेक्स्ट is very important, which is Annexure 6. Ma'am already mentioned during her presentation that why checklist is very important. हम हर कोई each and every point हम याद नहीं रख सकते जब हम फील्ड में जाते हैं, तो ये टूल इसीलिए डेवलप किया गया है ताकि हमें इसको पास में रखे एज ए सुपरवाइजर। जब हम फील्ड में जाते हैं आशा के साथ जॉइंट विजिट हो या फिर किसी और विजिट के लिए जो कि HBNC एंड HBYC चाइल्ड को कवर कर रहे हैं, तो इम्पोर्टेंट ये है देखना कि ये चेकलिस्ट हमारे पास हो एंड आज पर दिस चेकलिस्ट हमें देखना ये जरूरी है कि आशा के पास सारा इक्विपमेंट है कि नहीं। जैसे हम पहले ऑलरेडी डिस्कस किए, आशा के पास सारा चेकलिस्ट है कि नहीं, आशा के पास किट्स है कि नहीं, आशा के पास नॉलेज है कि नहीं। दिस इज वन एस्पेक्ट। द अदर एस्पेक्ट इज कि आशा के पास वो स्किल है कि नहीं। जैसे आशा को ट्रेनिंग में दिया गया है जो सॉफ्ट स्किल्स एंड द स्किल्स टू चेक द चाइल्ड अंडर HBNC एंड HBYC एंड फ्रॉम द पेरेंट्स पर्सपेक्टिव। द थर्ड एस्पेक्ट इज पेरेंट्स पर्सपेक्टिव। क्या पेरेंट्स को उसके बारे में पता है, जो आशा जाके पेरेंट्स को भी काउंसलिंग कर रही है या आशा जाके बच्चों को चेक कर रही है। तो ये 3 एस्पेक्ट, क्या आशा के पास इक्विपमेंट फंक्शनल है, क्या आशा के पास वो सॉफ्ट स्किल और जो स्किल जो है टेक्निकल स्किल वो है कि नहीं, एंड पेरेंट्स के पास वो इंफॉर्मेशन पहुंचा कि नहीं. तो दिस इज फ्रॉम द HBNC पॉइंट ऑफ व्यू से. सो सिमिलरली हमें HBYC प्रोग्राम जो है उसका नेक्स्ट पार्ट 2 है, उसका HBYC पार्ट है जो 3 मंथ्स में क्या देखना है, ताकि सपोर्टिव सुपरविजन के दौरान आशा फैसिलिटेटर वो देख पाए क्या आशा प्रॉपरली कर पा रही है. नेक्स्ट पेज में भी सेम आपका 6 मंथ्स, 9 मंथ्स, 12 मंथ्स एंड 15 मंथ्स के दौरान HBYC के विजिट के दौरान क्या आशा प्रॉपरली चेक कर रही है, क्या आशा करेक्टली चेक कर रही है, क्या आशा के पास इनफ इंफॉर्मेशन एंड स्किल एंड नॉलेज है, क्या आशा कहीं लैक कर रही है. अगर कहीं लैक कर रही है तो आशा सुपरवाइजर, ANM, MPW या CHO जो भी सपोर्टिव सुपरविजन में जा रहे हैं, they should assess it, they should keep the record of this remark where exactly ASA need the supervision, ASA need the skill enhancement, ASA need the supportive supervision or any further training or any skill improvement or any replenishment of any equipment or whatever the tool, whatever the kit that ASA have. So she need to see this so that she could write down in the remarks column, and in the further, as my madam says, as a team leader, she can support her at the latter stage and sometimes with a hand-holding process also at the field. So the services of the HBNC and HBYC program could be improved. So last but not the least, the Annexure 7. अगर आप सपोर्टिव सुपरविजन कर रहे हैं तो आपको इसको रिपोर्टिंग करना भी जरूरी है. तो इसका रिपोर्ट करना भी जरूरी है. तो Annexure 7 is that. तो अंडर Annexure 7 तो HBNC and HBYC सपोर्टिव sorry this इसमें तो and it is not showing for some technical problem or some. So you can see in your book or if you have the soft copy. So in that, in the Annexure 7 is there. So HBNC and HBYC supportive supervision reporting format is there. For ASA facilitator, ANM and MPW, this is a quarterly format, needs to be filled quarterly. And this is basically for HBNC and HBYC program where ASA supervisor, ANM or MPW and CHO, those who are doing the joint visit with the ASA, and this is expected that around 30% children from the HBNC and HBYC age group should be visited under joint home visit. And these children should be from the special category, which is LBW children. They will give emphasis to those children, either low birth weight or premature child, or any SNCU graduate child, or any child who has gone through the NRC, any child who is having any birth defect or developmental delays, or any sick child or sick child follow-up. So these kind of cases, special cases, or any child who is marginalized or outreach child. So these kind of children could be identified and plan could be made accordingly by the ASA facilitator, ANM, who will do the home visit to those particular cases so that a joint visit could be done with ASA. And अगर आप इसको देखें, then एक साल में almost 30 cases जो है एक साल में HBNC के and 30 cases एक साल में HBYC का चिल्ड्रेन को विजिट करना है. ताकि पर मंथ अगर हम कैलकुलेट करें तो केस लोड विल बी पर मंथ 2 से 3 आएगी, 2 से 2 to 3 चिल्ड्रेन फ्रॉम HBNC ग्रुप, 2 से 3 चिल्ड्रेन HBYC एज ग्रुप से। एंड उस पर्टिकुलर एज ग्रुप को अगर आपको पर मंथ विजिट हो रही है, देन आप आइडेंटिफाई कर सकते हैं कि उस पर्टिकुलर चाइल्ड का रिक्वायरमेंट क्या है एंड उसको किस तरह से सपोर्ट सिस्टम के थ्रू दिया जा सकती है। सो दिस इज वेरी इंपॉर्टेंट। एंड ये जो फॉर्मेट है इसमें नंबर ऑफ चाइल्ड अवेलेबल इन द कैचमेंट एरिया, HBNC चाइल्ड कितने हैं एंड HBYC चाइल्ड कितने हैं ये भरना है। नंबर ऑफ चिल्ड्रेन रिसीव्ड जॉइंट होम विजिट अंडर HBNC एंड HBYC, नंबर ऑफ चिल्ड्रेन विजिटेड फॉर, जैसे मैं डिफरेंट केसेस बताया, LBW, प्री मैच्योर्ड, हाई रिस्क, मालनरिश चिल्ड्रेन एंड चिल्ड्रेन अंडर डेवलपमेंट डिलेज जो कि 4 Ds है। नंबर ऑफ चिल्ड्रेन रेफर्ड आउट ऑफ दिस फैसिलिटी आउट ऑफ द होम विजिट ये भरना है अंडर HBNC एंड HBYC कलम के अंडर। एंड नंबर ऑफ चाइल्ड डेथ रिपोर्टेड, this has to be also filled under this reporting format. Number of child report death covered under the first brief investigation report by ANM, that has to be reported. Number of ASA given on job mentoring, if you are giving mentoring support hand holding आशा को दे रहे हैं ड्यूरिंग द होम विजिट, आप इसको भी मेंशन करेंगे एज ए पार्ट ऑफ सपोर्टिव सुपरविजन रिपोर्टिंग फॉर्मेट। So, and this to be and the number of formats submitted to PSC CSE for ASA's incentive payment, number of meeting attended and discussed on HBNC and HBYC issues that need to be captured. And if you have any specific remark, so there is a remark column under, there is a remark column also, so you can mention ki what is a particular remark, if there is a specific attention need to be given by the district official, state official, or so that need to be mentioned in the under the remark column. So this is all about the supportive supervision reporting format, which will be introduced soon to the all states, and this need to be reported. So thank you so much for your patience to listen all these annexures. And I may request Maya ma'am if she has anything to add on as our expert.
Well, I'm not going to add, but I just want to say, don't get so scared. Okay, these are very simple tools which will only make it easier actually for you and for everyone. So, but go through them. And if you don't understand some of it or it's confusing, make sure you check it with your district trainer or your district person so you are clear before you explain it to others. Okay. Usually all these formats, people get a little scared. Oh, how to fill it? What if I write the wrong thing? They're not difficult. And if Asha can fill it, anyone else can fill it. Okay, so don't get worried. But you've explained it very clearly, and now you've seen what it looks like. There was a question that the supervisors format in Annexure 7 is not in the handbook. So that will be shared later, I'm assuming.
Yes, ma'am. We will. I hope whatever the mail we have shared that must have. If not, we will share again, ma'am. We are sorry for this lacuna. Somehow this is missed by
not
us.
Not at all. Not at all. Don't worry. I mean, it's just something that they can read. The new man, okay, Dr. Pankaj has put in a link there where the Annexure 7 is available. So please, you can download that soft copy. It's on the chat box. Download it. Don't wait for someone to send you one hard copy. It will never come. Just download this and print it out and keep it with you.
Yeah, can you hear us?
Yes, we can, Syed. Yeah.
So whatever the link are shared in the chat box, that is the final module, and you can visit our NHSRC website also. So there is a Annexure 7 in the module, so you can check in the module itself.
Good. So that's very easy for you to follow. If you can't download it from this chat, go to the NHSRC website and look for handbook, and then you'll get the latest version.
in addition to this, ma'am, we'll also share to the all states again with the mail.
Yeah. Yeah, but what happens sometimes, you know, by the time it reaches the CHO and all, it will take some time. So it will be difficult. But y'all are smart enough, and technology, y'all are very, very smart. So I'm sure you'll be able to download it for your own information. I just wanted to say now, they've been sitting for 2 hours. So I'm going to ask them, hopefully everyone's still there, to stand up, drink some water, you know, and we should be able to restart in another 5 minutes if you want to just stretch a little bit. And what is the next session is mainly on future planning, isn't it?
Yes, ma'am. We'll be discussing on the planning for training rollout for CHO, ASA facilitators, ANM and MPWs at the state level and UT level. So that is the next session to be taken by Mr. Sarath Kumar Singh.
I can see that is written the state level interaction. You still have planning to have that, and how would you do that?
Yes, ma'am. I'll take only 5 minutes to just give the brief for the planning, and then we will start the state interaction. We will invite Dr. Shumta Ghosh, madam, to also join this session. So let me just give a few. I'll be sitting there. No issue.
So there is a last moment change in the agenda, ma'am. The planning is will be doing
it's
first.
Okay, it doesn't matter. If everyone understands that, now is a chance for you to get an idea of what's going to happen after today, which is your job to a large extent. So it's important you hear that. And then you'll get a chance for different states to have a little bit of interaction, give feedback, not only on today, on any doubts that you have. So, but in the meantime, drink some water, stand up, stretch a little bit.
Yes, I think that is most important, because we have spent at least more than 3 hours right now. So now 2 hours, yeah. So now my job is to just explain the planning for this this training, basically supportive supervision handbook training for our ASA facilitator, ANM and CHOs, including W also. So my request to all the states to put some financial provision for that. I know that state of Maharashtra, state of Gujarat, they have already budgeted for this training, and they got approval, and they are doing it. Maharashtra and Gujarat, they are doing also. They are in planning to do this supportive supervision training. Though we have written in the handbook that 2 days training, but we found that that could be sufficient, 1 day sufficient for this training. However, if state wish, they can conduct 2 days training and some additional kind of refresher training can be done on first day, like orientation of our program for if new supervisor are in the program, and then they can conduct this training for the supportive supervisions. My request is to all the state nodal officers and the district level officials, first let it translate in the regional and local language, because that training would be conducted at the block level, so that the our handbook should be available in the local language, like in Gujarat in Gujarati, Maharashtra in Marathi, Assam in Assamese, and Northeast there are various dialects. So in their regional language, it should be translated first. And then the planning of training, the batches they should plan, and also the financial provision. Since we are receiving our supplementary PIP, so the state who have not, which have not basically made provision for this training, they can propose in the supplementary PIP, or this time it has a flexibility to the states. They can use budget from another head for to conduct this training. Just to get the approval of their mission directors, and they can get that financial, because now there is only NHM pool and then RCS Flexi pool, and all these pools are merged. So there is no issue of fund to conduct any of the activities that can be done just to process for the administrative approval from their mission director. They can conduct this training and they can report it. So with this, since we have also got this information, and Annexure 7 is not available in the shared PDF, but it is not available in the revised, which we just Pankaj has shared to all the states. So my request is that once the training will be completed, the home visit by the ASA facilitator, even our supervisors would also should be initiated. And after that, the monthly, it's the quarterly progress report for the supportive supervisions. We will be asking to all the states and UT to submit this report on quarterly basis, like that. If they are submitting the report for HBNC program, for HBYC program, then there would be another format for the supportive supervision. They will be submitting, state would be submitting this format to national level, so that we could also assess that the supportive supervision is being happened in the states, in the districts, and to improve our program implementations. That's all about the planning. We will also discuss in the there is no audio. Yeah, audio is there. Maybe there is some internet issue for some of the participants, but it is, I think, audible to all the our participants. So with this, I would stop here, and I think the planning because please go ahead. So Pankaj, Dr. Bala Subramaniam has joined us, or what is the plan of Dr. Bala Subramaniam?
Dr. Sharad, I just want to ask you, in the beginning, you had one slide which showed after this meeting what are the next levels. Do you have that something to share with them? Because going forward, at least they can revise what they're supposed to do after today.
Yes, ma'am. Yes, ma'am.
So before we end the program, if you show that slide, it'll help.
Yeah, sure. We will share it. We will definitely show these slides. Yeah. Which Dr. Sumita Ghosh madam has already shown.
Yes, the first slide, I think. Yeah.
Yes. We will show it. So if there is any planning issue, we will definitely discuss with the states, and they can. And I would request NSRC team to facilitate this state interaction. Maybe they have jot down all these questions from the state, so that we can answer their queries. And if some of the states nodal officers wants to speak, they can facilitate them to speak regarding their queries. So we will wait for 5 minutes. Let Dr. Sumita Ghosh madam join us, so that it would be more interactive too. Pankaj, over to you, and I'll be requesting Sumitra to ask madam to join us.
Okay. Thank you, sir. I have requested Bala sir to join for way forward and vote of thanks. So meanwhile he joins, so we can go to ma'am to join the meeting, and we can go with the state interaction round. And the question answer, like the lot of question has come in the inbox. So we can go with the question one by one. So till the time sir will also join, and ma'am will also join. Yeah.
And why don't those who still have questions write down your questions quickly and send them, so that they can either add it to the list or whatever. Yeah. Remember, we're talking about questions that could be about the handbook. It could be questions related to what you're supposed to do after today, or it could be a doubt from any of the presentations. So if you have any of those, write it in any language. I've come on chat, Pankaj. So if someone's collecting them, just make sure that it's done. Yeah. Don't worry too much about administrative questions only. Yes, you can ask them, but also ask any other technical or training related questions.
And if anyone want to interact with us from state, district, they can also, raise their hand or, put a message in a chat box. So accordingly, we'll make them panelists and they'll get, chance to, talk and directly to ma'am, sir, and Maya ma'am, anyone from state or district. So they can raise their hand or they can, put a message in a chat box. So accordingly, we can make them panelists one by one. Yeah.
Just make a note of some questions that are coming on the chat now. Huh?
Pankaj, we can start with the state interaction or question answers. Can you just
Okay, sir. So, sir, I have collected all the question in a word sheet. Do you want me to share that sheet in here, or should I just,
You can read the
the
important
question one by one?
you can read important the questions which means Sumita Ghosh madam may respond in some question, Maya madam may respond it, so you can read it.
Okay. It would be better if we can share on his screen.
Okay.
You can also share
So just give me a second, sir. I'll share the.
Click to now, we'll share. We'll share. We will share over the email. Good question. Very good question. Actually,
So is this visible?
Yes.
Yes, it's
Okay.
visible.
Yeah. So here are some important questions, sir and ma'ams, which came from states and districts. So which we thought like relevant and to revert back to the state in this regard. Like the first question came from Dr. Seema Garg from Hoshiarpur, Punjab. Like, can Government of India provide MCP cards to states, please? So, ma'am and sir.
Yeah,
Cards are available everywhere, every village, everyone. I think so.
Yes.
I don't know, Dr. Ghosh, isn't that true?
MSP card, it's budgeted under PIPs and state is as much as they want. We support the states. States are support, and all the versions are also sent to them, English, Hindi. So they are supposed to print it and give it.
I would only say that some of the states have them marked with ID numbers or holograms.
Yeah.
So you can just photocopy it for your own reference for training purposes, but it's available in almost every single state that I have seen. in their local language.
Yeah, and you can make some innovation also, like if you want to. Many states have done, their own language, own innovations also in the front page for there. And now ABHA ID and all will be coming. So it is better that the states, they according to them, without altering the content, like they can revise, they can suit their own purposes.
Okay. The second question from Mohammad Sadiq Khan. So they asked like Ashas and Asha cadre need reorientation. I think this is in regards to HBNC and HBYC both. So,
Yeah. Maya, you will be answering or should I?
No, you can answer.
Yeah. See, orientation, they have already been trained and modules have been taught. So the monthly meetings and all, we should see such kind of opportunities also, where we can give them reinforcement of whatever has been trained. And even our supervisors, they can also train them. And again, going through the whole reorientation, of course we can, but let us explore the informal challenges like, monthly meetings, then on-field hands-on, all these things can be done. And HBYC, it is already in the process. So if needed, if someone feels that this, some people need reorientation, so they can be recalled.
I would say a very practical way to handle it is don't wait for time and all this takes very long. During the next monthly meeting or staff meeting that you have at PHC, sub-center, whichever level, just conduct, take the HBYC card or the HBNC form and start orientation in small ways, instead of waiting for a formal training. That will come for the new Ashas and this thing, but in between this can already be done by the people already on the field.
Get any material on this?
What is the third question? Can you get any material on this?
We will share all the PPTs information.
Of course, we'll share the PPTs.
So that they can do the
Yeah, they can be used for further training.
reference.
And we can see. We can see the 4 questions. The book should be supplied to his district. So it has been shared to all the states and UTs in the Hindi and English version. We will request all the states for Hindi speaking, they can use the Hindi version, but for other regional language, they should translate this handbook in their regional languages, and then they get printed and it will be supplied from the state to the districts and further down level. That is. And
website also has this. Our NHM website also has this. So anyone interested can read from there.
Yes, ma'am. Introduce. Can we sanction the ASA facility and cooperation? Yeah. That is the NSRC purview. Question 5.
What is?
Can we sanction the ASA facilitator in corporation areas, urban areas?
So this question need to be replied by Bala sir, and he is going to join very soon. Pankaj, please just
Okay.
question first can be we can cover later on.
अच्छा ये 6 numbers कौन से state से है, district से है? Because most of the districts they have most of the state they have received fund for the HBYC CD kit, but the procurement at the state level is under process. Probably once they will procure this HBYC CD kit, they will supply to state from state to district level. It will be supplied. So our
State nodal officers to note.
So my request to all the state nodal officers, please ensure that the procurement should be processed on the time which are approved for this financial year and then supplied to all the districts. HBNC basically not provided to us. So wherever there is a problem for the HBNC and HBYC, my request to all the state nodal officers, the adequate financial provisioning should be made in the PIP, even in the supplementary PIP, which are still
Scope is there.
So that can be provision in the PIP, and then it should be supplied to this. Can you share this checklist, ma'am? Yes. Yes, all the checklists should be shared. This guideline and PPT should again would be shared to all the state level officials. Further, they will circulate to their districts and block level officials. Is there any availability of the checklist regional language? Yeah, we have already mentioned it that it is in Hindi and English. So for other regional language, state nodal officials should do this translation in their regional languages, and then like in ASA handbook for the HBYC program, it was translated in regional language in the states, various states. Then it was used for the training. The similar way, this handbook should also be translated in the regional languages, and further the training would be conducted with the help of this handbook. Yeah. Next.
Question 9. Question 9. So that is the state responsible to regional.
See, the thing is, all the questions about availability. So the guidelines are there, the books are there, and they are also on the websites. So state can take initiative so that these are translated if needed, if the printing, and then supplying at the district level, because this will help the program a lot. So prioritize that, and I believe all these have been accounted for. So see into it that they are done.
There was one question from the Dadra Nagar Haveli and the Mandir. They have asked, they don't have budget for this budget constant, but they want to conduct this training. So probably the supplementary, if they could able to propose it to be ma'am, with your permission.
Yeah, you can always propose it. There is a scope now. But one thing is, so many things are now in the field that the handheld things and all. Though there you can give a soft copy, so it is easier to retrieve also. Checklist and all. When you go, you can take that along. So that kind of things can be also resorted to if there is a budget problem and there is not enough budget left for it, for repositioning it. But you can always ask here, and if it permits, the state resource permits, we have no objection to it.
Pankaj, any other questions left?
Sir, there is one question from State Health Society Bihar. They have, raised a question regarding request to increase the incentive of ASHAs under HBNC from 250 to 500, as it is not revised since inception. This is what they mentioned.
This is not an NPCC meeting. We are not. Of course, we know things, are there and demands are there. Kindly raise this in NPCC. A review is coming.
To attend another.
I think Dr. Sir has joined.
Yeah. Hello, Dr. Bala. Dr. Bala has joined.
Ma'am, he is there, but might be there are some, this network glitch or something. So we are trying to solve it out. Yeah.
Any other question?
Yeah.
Sarat sir, there is one IT related question from Amit Kumar Shrivas. The district or state is not mentioned. So they have mentioned like nowadays ASHA facilitator and all supervisors are using Android. So is there any planning to prepare any Android based tool for supportive supervision checklist so that the structured data can be analyzed, which will be reduce manual exercise?
Yeah, we will think of it. It can be easily translated. It
yeah,
can be done.
It can be done, and we are under process of developing HBNC, HBYC
Portal also, yeah. What
So-
portal we are doing? So we'll put that. Yeah.
So supportive supervision checklist and format should also be. And I understand that we are also aware, ma'am, that state of Uttar Pradesh already doing that supportive supervision visits and monitoring through Android-based applications. So we will explore it and we will definitely devise it and we'll share to all the states in due course of time. Yeah.
Yeah, these days it's easy. We can. It can be developed.
There is one more IT related question, sir. Like same from HSS State Health Society Bihar. When we'll get the HBYC online portal, as state has taken budget approval from the data entry operator as incentive for data entry of HBYC. This is what they are. I think they are talking about the HBYC online portal. Like, is there any proposal or any?
It is under process. It is under process. Very soon we will be finalizing it, and we will conduct a pilot for that, and then it will be shared. So it is under process, and
it is almost, you can say, 70-80% done.
Yes. Yeah. Pankaj.
Yes, sir.
Dr. Maya could not able to join. Just
panelist बनाने की request है.
Okay. Just a second, sir.
इंटरनेट में चला था
बार-बार ज्वाइन करता हूँ, वो री-रजिस्टर करने को बोलता है, मेरी स्क्रीन पे नहीं दिख रहा, हमें स्क्रीन पे दिख रहा है.
देख रहे हैं?
Maya ma'am, are you there?
Yeah, thank you so much. You know, there was a technical thing and I had to change laptop, so that's the problem. So sorry. But I could hear, but I couldn't. So I don't think you should ask administrative questions which can't be answered. This is an orientation technical. I know you have a lot of administrative glitches, but that's a state-wise. Goa, you don't have ASHAs, but I'm sure you have people in the field, HBYC and HBNC still being implemented as a program. So you'll have to figure out who's the person that you'll have to work with. I think so. That's right.
I think medical officers are doing it.
Ma'am,
Kerala, I think.
In Goa, HBNC and HBYC program is not being implemented because they don't have a ASHA, and since long back they have opted off. They will not implement this program and with their issues. So.
But this information is helpful for anybody there in Goa.
Yeah, sure.
I mean,
sure,
the child is still there. The child is not absent.
I feel in Goa being a small place, so community, this thing is not so well developed, like separate programming and all. But it can be, this supervision checklist can be useful.
Yeah.
And ma'am, that's the reason why we share all those mails and the related materials to Goa as well.
Absolutely.
This is shared with Goa.
So I can
whoever's
submit.
from Goa, I'm from Goa, you are developed as much as Kerala. Your villages are almost semi-urban, but there are healthcare workers there. You have PHCs. So you should just ask your LHVs and your ANMs from there to take over the supervisory role. Your child mortality and morbidity data is very good. I mean, but keep it up and make it 100% now and be a role model like Kerala. So don't wait for a formal program and things. Just download all the handbooks from the NHSRC website and be innovative and use it. Sorry.
I see a scope. There's HWCs and all which have come up, the CHOs. They can actually benefit a lot. They can learn about the programs and they can do this thing, both where HBNC, HBYC is not there, but they are there, so they can make community visits. They can do, it's a very important thing to be promoted. Supervision and community work, both are very important for our programs.
So we can talk separately to Goa states. Like Chandigarh is also implementing HBNC and HBYC through link worker. They are the ANM. So this program can be implemented if state wants to implement it. Earlier, because they said they don't want to induct ASHAs, so that they would not implement it. If they are willing to initiate this program, they can initiate with their ANM and they can start this.
See, the community-based programs' importance is that all children do not always come to facility, but they need a continuous, kind of monitoring because of their growth and nutrition. They are serially they should be followed. So for children, not only facilities but community-based programs are equally important for empowering the family as well as for checking their growth monitoring without making them come repeatedly to facilities. So the states, which of course Goa is doing quite well. So but still the need remains.
And ma'am, we are happy that today Goa team has joined this orientation. Goa team has joined with us.
That's good, excellent. But there's some very specific things. Somebody from Assam has said they shared an Excel sheet. I can't see it, but for tracking pregnant women who are migrating. But someone from Bihar in Jahanabad has said that there are very specific issues. So I think some very specific local issues the state level people will need to look at. And if they're not answered, then you can probably approach the ministry. This thing, but small things. And like I said before, don't wait for a formal orientation for HBYC, HBNC. Just do it at all your meetings. Every meeting, take up one small topic and do it. It's not such a big thing, in terms of content.
So
if there is no more questions, so can wind up.
Yeah.
So Bala sir is there.
Pankaj, Dr. Pala is here. Sir is here.
Ma'am, there is some technical glitch. We are just coordinating with Bala sir. I think he is joining with his phone, so we will keep his phone on his speaker. Maybe he can speak.
Okay.
We can see his window here, but it's
ma'am, but there is no. I think there is a network issue. He is not able to speak.
Okay.
Let him join. We'll wait.
Maybe Dr. Sharad, show that one slide which shows in the meantime what after this program which Dr. Ghosh is showing, today's program, what are the next steps so that they can just kind of refresh that while we're waiting for Dr. Bala.
Bala sir, our advisor CPC has joined us, but he's on because of the connectivity issue, he's not able to join us on screen, but he's with us on the phone. So Bala sir, over to you.
Good afternoon, everybody. I'm really sorry for actually interrupting a long conversation. I did hear a lot of conversation between Dr. Maya, Dr. Ghosh, and others. I'm not able to join as a panelist. I've been seen as an attendee, so I'm not able to unmute. I hope I'm audible now.
Yes, sir.
Okay, thank you very much. I think this was a very short but sweet session that you have all had since morning. I'm sure though it was a webinar with a large attendance, which was welcome, we still miss you seeing face to face on many of these issues, but at the same time, we really appreciate the enthusiasm with which all of you have joined. Can I have the people to just share their experience of their learning today and any specific two comments that they have in terms of either the training program by itself or in terms of improving the future programs?
You can put it on chat quickly.
They can send messages on chat.
Message, yeah, okay.
Okay, just check.
So if you didn't hear Dr. Bala, he said that anyone wants to give some feedback on today and today's session and any other suggestions.
Few people can raise their hand now.
But he can't see the thing. Can he see the chat?
Is there any specific inputs that they would like to share?
Why have you all grown silent? Well, I was so active all this time. So quickly, just give whatever feedback that you have specific.
Sir, meanwhile, the state asked the question. So there was a question came in a chat box previously regarding the ASHA facilitator. So Dr. Parmar asked a question like, can we sanction ASHA facilitator in corporation area? I mean, in urban area also. So this is what he raised the question.
Yeah, I think it's a very important element that he has raised. This has been a matter of long debate for the last at least 1 year plus now on the National Urban Health Framework, which is presently being redefined. Hopefully, we would be able to get the answer for this in the next 1 month once the ministry formally authorizes, looks at it and agrees for many of the issues. So while we do appreciate that, especially in the context of the current framework where urban ASHAs are also, I would say, need a supportive system, and MUHM by itself, by one urban nodal officer, is not able to fulfill many of these mandates. A structure similar to the rural areas, but more in terms of synchronizing or converging it into rural areas support structure might be a worthwhile option, is the experts' opinion. This has to be further vetted by the ministry officials, and subsequently we'll be able to get to know maybe in a month time from now. But one thing is very clear, that the tiers of Mahila Arogya Samiti has to be augmented with another urban health, sanitation and nutrition committee too, and the support structures in terms of the CP nodal officers who exist for only rural areas today should also look at urban areas, so there is also convergence of it. So these things are definitely coming up. ASHA facilitator is also being deliberated. It depends on the availability of resources and in principle agreement from the ministry, which could happen maybe a month or two from now.
Okay. Thank you, sir.
I'll have to take leave. Thank you all for joining, especially last moment, Dr. Bala also could join. So let us move ahead with it. And I would request to carry on after this and vote of thanks and all. I just have to leave because there's a message that I have to attend something. Okay. Vote of thanks. You can go on.
Thank you very much.
Thank you, ma'am.
Yeah. And all materials will be sharing. Okay.
Yeah. So further, are there any inputs from any of the attendees?
So no inputs per se, but there is a message, like it is a great experience to get this kind of orientation about HBNC and HBYC at this platform to improve NMR, IMR and under 5 mortality. And it will help into reduce morbidity too. And a lot of thanks, sir. A lot of thank you messages, that's it. No feedback.
So thank you very much. In fact, I have only one input with respect to this. See, India has done extremely well in terms of the home-based newborn care, and our IMRs are definitely coming down. But when it comes to HBYC care, which has to be looked at on a more extended framework, I think a lot of states had to roll out their training program and subsequently actually implement and monitor the roles performed by our own ASHAs in the field level. So net result is, when we visit states, there are very few states where HBYC program is actually active. So if we want to achieve these goals of sustainable development goals, as well as the national health policy goals, India has to march forward in terms of ensuring actual implementation beyond learning assimilation. So knowledge assimilation is definitely accepted, is an important conduit in the whole process. But I would still urge each of these nodal officers who have joined us today to not only ensure transfer of knowledge and skills to the grassroots level functionaries, but equally important would be to be the monitoring of the same. Because it is a normal human tendency that we all would perform whatever is measured. Even in an examination, if there is a very little marks allocated to a chapter, we tend to skip those chapters even during reading. So unless and until HBNC and HBYC becomes a mandated review parameter on a monthly basis, actual effectiveness on the field would be far-fetched. So I really urge each one of you who have enthusiastically participated, have learned about all these things, the knowledge is actually transferred onto the grassroots level functionaries, as well as ensured that it is implemented by a monthly review. So I hope that we would be able to extend our continuous support for any of the specific queries that you might have at any point of time from NHSRC. You can count on us to actually knock our doors at any point of time, and we will do our best within our limits to ensure that we will be able to respond to you on time and probably on the expectations that you have. So I look forward to interacting with you. The midterm reviews are anyway taking off from 24th. So many of the functionaries, at least the state level representatives, would definitely be visiting Delhi, and we will have a live interaction with each of the 36 states and union territories. So we look forward to answering any of your queries at that point of time. And I also urge you that this element of HBNC and HBYC is given due credence even in your PIP process, that is the project implementation plan, because unless the states put it up in plan, resources are hard to come by. So I would urge each one of you to prioritize resource allocation for these in your PIPs, and whatever queries that you have for discussions, you please bring it to the PIP discussions that we have for the midterm review starting from January 24th onwards. So I look forward to meeting your state officials in person. I once again thank all our distinguished resource persons, both from the Ministry of Health and Family Welfare, as well as Dr. Maya, the master trainer, who has been with the NHSRC with us for a long period now. And she has been part of all the supportive supervision programs. I also thank all the NHSRC consultants, Dr. Suman, Dr. Pankaj, Dr. Jyotsna, Mr. Syed, so who all have joined for making this program a reality on this day. So once again, thank you all.
Thank you, sir.
Thank you so much, sir, for your kind words and your vote of thanks for this important virtual meeting orientation of this supportive supervision handbook. On behalf of Ministry of Health, I would like to again thank you NSRC team for organizing it, giving us time for that. and Dr. Maya Madam for your time, valuable inputs, time, and guidance for the supportive supervisions for strengthening of HBNC and HBYC program. We are really thankful to all the participants, especially those who are posted in Health and Wellness Center. We saw that many of the CHOs also joined this orientation meeting. That would be really helpful for them also. And I would request our state and district nodal officials to carry forward these activities. And we are here to support states for this orientation workshop or sensitization and provide the technical support as and when it is required. Thank you so much. Thank you so much.
Thank you, everybody, and have a good day.
Thank you. Thank you, everyone.
Thanks, Pankaj. Thanks, Syed and Suman, who was there. Thank you, Sharad and team over there. Good to meet you.
Thank you, Sharad sir. Thank you so much.
Thank you all.
Thank you, Maya
Bye.
ma'am.
So have a
Bye-bye.
good lunch. Bye.
Thank you all. Thank you so much.
Thank you.
Good to see you all.
Yeah, thank you.